Health and Family Welfare in association with Government of Telangana. I am Chandra Sharma and I'll be your host as we embark on the journey to discuss the critical challenges, solutions and opportunities in the realm of the non-communicable diseases. I hope you all have enjoyed a wonderful lunch and I also hope you all had an insightful experience during the breakfast. So starting today, the session, let me take a privilege to talk a little bit about our Telangana state. Telangana is known for its rich culture, heritage, diverse traditions and the iconic Charminar. If you haven't visited, please do visit. And the state has also emerged as a center for biotechnology and pharmaceutical with a focus on development and inclusivity. Telangana is making significant strides in education infrastructure and welfare. And when we talk about this, the sessions for the afternoon are going to be very insightful to all of us. As we transition into the afternoon sessions of the National Workshop on Non-Communicable Diseases, we are truly honored to be joined today by a distinguished group of experts and dignitaries from and across the country. A warm welcome to all the dignitaries from the Ministry of Health and Family all the teams. Non-communicable diseases. We are truly honored today to be joined today as students. We really appreciate your presence for this. Thank you so much once again for joining and making this session really impactful for the coming years. Before we proceed with the workshop, first session, let me remind you all of the core focus of this gathering is to explore, learn and discuss the most effective strategies to address the non-communicable diseases. The fight against non-communicable diseases is a global responsibility requiring the collective action of all the sectors of the society. With this in mind, it is our shared responsibility to collaborate across government, healthcare, academia, and civil society to reduce the impact of diseases such as diabetes, hypertension, cancer, and chronic respiratory diseases. And now, as we begin our first technical session for the afternoon, we will focus on non-communicable diseases, priorities, and achievement. So ladies and gentlemen, this session will provide us with a comprehensive overview of the current landscape of non-communicable diseases care and management in India. The speakers will help us understand both the progress made and the challenges that remains, paving the pathway to collaborative efforts to find the solution. I hope the sessions will make a great change in the coming years, and without any further ado, let me introduce our first speaker, Dr. L. Swasticharan Sir, Additional Deputy Director General at the Directorate General of Health Service, Ministry of Health and Family Welfare, delivering a session on key priorities, achievements and targets of the National Program for the Prevention and Control of Non-Communicable Diseases. Dr. Swasticharan Sir, in his current role as an additional Deputy Director General and Director Emergency Medical Relief, he is responsible for overseeing key national health programs like National Program for Prevention and Control of Non-Communicable Diseases, where he plays an instrumental role in settling national health priorities, achieving key targets, and addressing the growing challenges of non-communicable diseases. And may I now kindly request you all to kindly join your hands as I welcome on stage Dr. L. Swasticharan Sir onto the stage. Please put your hands together as we welcome him onto the stage.
Good afternoon, ladies and gentlemen, and I'll be speaking as the first speaker, trying to introduce the National Program for the Prevention and Control of NCDs. The first slide gives us a glimpse of the mammoth task that we all have here. suggesting that we touch upon various organs of the body and causing various diseases like cardiovascular diseases, diabetes, chronic kidney disease, liver, non-alcoholic fatty liver disease, which we have picked up in this program, many cancers, but for training purpose, we are trying to concentrate on 3 at the moment, and the ST elevation, myocardial infarction, and stroke, etc. Can I have that mic? I can't see it. I can't see it here. Okay, thank you. And in order to take care of this across the country, we have established many administrative cells like the National NCD cell, and also many clinics which are known as the NCD clinics at the district level, as well as at the community health center level, and also special clinics which are known as district daycare centers for providing oncology, and also district cardiac care units and the tertiary cancer care centers and the state cancer institute. So we'll be coming to these components in a while now. The burden of the disease, we all know that globally NCDs are responsible for 74% of the mortality, and NCDs are also responsible for 66% of the mortality in India. So we are no longer different from the other countries. India, we say that we are suffering from a dual burden of the communicable diseases as well as the non-communicable diseases. NCDs are not just a health problem, it is also a sustainable development issue, and that's why SDG target 3.4 is associated with the NCDs and mental health, and by 2030, we do have a target of achieving 1/3 premature mortality from non-communicable diseases to prevention and treatment and promoting mental health and well-being. The overview of the NCD, therefore, in the next few minutes, I'll be speaking in terms of health promotion and awareness initiatives such as Eat Right campaign and a Fit India movement in an attempt to prevent the diseases from happening. And also, the whole of government approach is going to be achieved. We are going to try to achieve this through what is known as the National Multi-Sectoral Action Plan and the population-based screening for 30+ population and management of the various diseases that we have identified in the first slide, and also trying to monitor the whole gamut of activities through the NCD portal by means of data reporting, so that we have got a chance to see how we are performing and also try to correct them. And also the continuum of care of NCDs is very important in the sense that NCDs being a silent disease, many people are not diagnosed properly, many people who are diagnosed are not able to continue them. So the continuum of care is also to be emphasized in this program. Friends, for other programs, we have one program which looks after one disease. For example, we have got HIV program, the National AIDS Control Program looking after HIV disease, and also a TB program looking after TB disease. But in NCD program, we are looking after 10 different diseases, and each one of them also consists of many complications which will have implication on each other, on the various components of the program, as well as the outcome of the disease. Therefore, comprehensive screening, comprehensive taking care of all of them is a challenge in this. NCDs we need to consider this from the risk factors point of view also. We have got the NCD3 that we often talk about. If you look at the roots of the tree, we have got alcohol, physical inactivity, air pollution, tobacco use, not just smoking, and unhealthy diets, and leading to the different branches which are the various diseases that we have, which are non-communicable diseases. Therefore, to start the health promotive activities so that people continue to live healthy living in such a way that they do not indulge into any of the risk factors, we have many programs, and one of the programs, the National Tobacco Control Program, consists about various strategies. One of the strategies which is enshrined in WHO's principle is the Empower strategy. strategy. And also India is a signatory of what is known as the WHO FCTC, and we do have various articles of the FCTC to be implemented. And also India is a signatory to the illicit trade protocol, which is also taking care of the various components of illicit trade of tobacco. We have a dedicated national tobacco control program, which we will not be able to discuss here today. Alcohol, excessive consumption of alcohol is also one area which is being taken care of by the Ministry of Health and Family Welfare and MOSG. The Fit India movement of the Ministry of Youth Affairs and Sports also has age-specific protocols which promotes age-specific physical activity for the country. The Healthy Living, Eat Right campaign of the FSI also adds to the value of health promotion activities. And when the diseases occur, what usually happens is in India, 1.4 billion population, we have many people who would be indulging in many of the risk factors. So, and we will still have a population who would be already having the disease, but they would not have come across the healthcare facility, or they would not have, come face to face with the health functionary that they are being screened and they know the status of the disease. That's why the common NCD screening under the NCD program is very, very important. That's why we have initiated the screening of hypertension, diabetes, and 3 cancers. And we have devised current methods which is easy to be implemented by the healthcare facilities. Many of the speakers after me will be going into the details, so I'm just giving a glimpse of what we are doing. Last 4 years, few years, we have seen how the screening we have achieved in India. It is all the good work of all the health, of all the state governments who are present here today. We have we have grown by leaps and bounds. But this is one aspect of it. And then after we have done this mammoth task, whether we have done the continuous follow-up, whether we have diagnosed them properly, whether we have put them in the data that we are establishing under the national portal, that is a challenge, and for which we all are here today, and many speakers will be speaking on these various components once again. So we also strengthen the cancer care component by establishing what is known as the state cancer institutes, which are bigger institutes, which we fund about 120 crores of rupees, and the tertiary cancer care centers, or known as the TCCCs, where we put in about 45 crores of rupees. So the activities of the state cancer institutes ranges from health promotion to tertiary care cancer treatment. We are not saying that this is not the only cancer care facilities that we have in this country. We have got many aims already functioning, providing the cancer care services. We also have the medical colleges providing cancer care services, and we also have we also have many premier institutes like the Tata Memorial Hospital, all in the Institute of Medical Science, etc. The comprehensive cancer care program, we are once again trying to concentrate on the 360 degree of community awareness, spreading about the risk factors of cancer, trying to avoid them, screening them, early diagnosis, and also providing affordable and palliative care, and following them up in that cycle. The various documents that we have produced in the Ministry of Health and Family Welfare consist on various components. You can see many of the guidelines which we have already done for stroke, as well as the ST elevation, myocardial infarction, and also the chronic obstructive pulmonary disease, etc. And all these are available in Ministry of Health's website. And very recently, we have just revised the guideline on non-alcoholic fatty liver disease, one component which we have already added in the national program for NCDs, and the chronic kidney disease. And many of you have already visited the dialysis units in the nearby districts in Telangana, and we also would like to emphasize that whereas dialysis facilities are good to look at, they are life-saving equipments and institutions, but then we need to concentrate on the component of preventing the chronic kidney disease from happening, because these patients who are on dialysis are in a way on maintenance therapy, in a way waiting for transplant to happen, which doesn't happen that easily. So the component of preventing CKD by taking care of the hypertension, taking care of the diabetes, etc., is very, very important, and we need to emphasize that as well. We all know that we have a target. We are trying to push ourselves with what is known as 75 by 25, putting 75 5 million people with hypertension and diabetes on standard care by 2025. We are already in early January 2025, and we know that this is also one of the agenda of the Chief Secretary's conference every year. And as we went for the CRM, we tried to see how this is being done in the states, and we are very hopeful that India would have achieved this in many of the states already, and we would be overdoing it. But then we'll try to, come back and declare ourselves that we have achieved what we wanted to achieve, the targets of 75 by 25. And the National NCD portal is very, very important for us to maintain the continuum of care, also provide directions in which way the program is going, and we are able to correct ourselves. And this is a very robust system which is done by the Ministry of Health and Family Welfare. And starting from the lowest health functionary of ASHA to the CHOs, to the medical officer, PAC, to the district NCD cell and NCD clinics, and the state cell and the national NCD cell, etc. We are all linked with this, and we do have some challenges of some of the states not able to, get on board on this, but we are hopeful that this data system, this IT platform that we have for NCD continues to improve and provide us guidance for future. Then we also saw many of the facilities today. Some of us, we even tried to see the functioning of eSanjeevani, and the NCD is one program. NPNCD is one program which utilizes the eSanjeevani platform of the facilities for consultation for many of the follow-up patients or the new patients for hypertension, diabetes, and the 3 cancers. And we could see it happening in the field in Telangana today during the field visit in the morning. Then the continuum of care is one very important thing. We know that whenever we see any patient in the primary healthcare delivery system, the moment we say that you could be suffering from cancer, then he or she skips the whole pathway of referral, and that person comes up in one of the premier institutes of the country at Tata Memorial, or in the nearby medical colleges, or in All India Institute of Medical Science, etc. And then we lose track to where that patient has gone. And then after that, after the patient has been diagnosed and treated, and if he is to be put on treatment, he comes back to his district, then he still, tries to go back to the center for follow-ups. And then many of the other activities of commercial burden, the economic burden, etc., also sets in. So the whole system that we have tried to set up through the NPNCD program and other programs of the ministry gets defeated. So the continuum of care, in terms of the referral system, in terms of how we are going to track it through the IT platform, is one area which we are also trying to emphasize, so that we have optimum use of whatever is available to us. Friends, we all know the universal health coverage under the Ayushman Arogya Mandi is also one component, and this has got a very important role for NCD in particular. That's why we have brought in the slide here. The essential packages include screening, prevention, and control of management of NCDs in the expanded services, in terms of the health promotion, and also reaching the last mile. And if you see in the slides that if you remember in the slides that we have cases of stroke, we have cases of ST elevation, myocardial infarction. These are going to be medical emergencies happening in the community, and the community should have been empowered to know that there is an ambulance service, a pre-hospital service in the particular state. They should be able to call the system. They should be able to get the ambulance in time, the right ambulance with the right technician whose capacity has been built, and that ambulance should be guided by a system to take them to the nearest hospital which has the appropriate care for that particular district. So that kind of theme-based approach, ensuring continuum of care, is also to be ensured through the universal health coverage theme of the NHM. The current challenges include health promotion and behavior changes. We all know that we ensure that we ensure, and we should continue to ensure, antenatal checkups, healthy delivery, then immunizations and institutional delivery, then immunization of the child, and then let them grow with RBSK and RKSK covering. Then after some time, we seem to forget them. And then we wait for the risk factors like tobacco, alcohol, and other being influenced by many factors. And then when we start remembering them when they are 30 years, and we try to see them whether they are suffering from the NCDs. So that is giving us a backlash, and we need to continue to guide them. We need to continue to guide them in such a way that lead healthy living, doing away with the challenge. Screening, we do have good screening, but there are other issues with screening, particularly cervical cancer, because of various cultural barriers. We still have very low screening of cervical cancer. Some of the facilities are still not yet available in the Ayushman Aroga Mandir. We have cancer experts going to speak on that area. The human resources, this is varying in various states. They do have many capacities, different capacities in different states, etc. And that itself is a challenge again. The infrastructure to some extent has come up at the primary sector, but if you see the first slide, we remember that out of the 740 plus districts that we have, the number of CCUs and the cath lab and the stroke unit at the district level hospital is very, very low. So the good states are picking up, other states are not yet to pick up, so we need to push this component. And also the monitoring and evaluation, we do have what is known as a national NCD monitoring survey, which we have done the first round. So we need to repeat that to see in the ground whether we are gaining grounds in terms of implementation of the NCD program or the policy. The NCD portal, we have certain challenges in terms of some states not being on board and some states are not being able to update the information as it is required. And in the way forward, we are trying to go ahead in full swing in the community awareness with community participation. With the health of the individual should also be in his hands, not just in the hands of the government, all of us. It should be in his hands. So that will happen only when we empower him with community awareness, personal awareness, integrated approach by leveraging the technology. So many of the patients who are suffering from NCDs by virtue of the burden of tobacco could be a tobacco user, by virtue of the fact that he is suffering from diabetes, can also suffer from tuberculosis, by virtue of many factors he could also be suffering from mental disease. So they come up at different points of healthcare delivery system, and if we don't integrate them, we continue to address individual disease conditions and components of the program. So that leveraging technology in such a way that we will deal them as a whole, trying to offer them all the services that we have in the system is one which we are thinking. Strengthening of the CAC and the DH for early referral and confirmation, like those best performing district hospitals which have been upgraded even to the extent of medical colleges in many states is one of the focus areas. Capacity building we continue to do by training and retraining of health workers and maintaining electronic health records, and also generations of the AVA IDs. AVA IDs generation, if you have a number which is unique, wherever you go, right from the Ayushman Aroga Mandir to the tertiary care centers, we will be able to track you, we will be able to help you follow up the patients. So this is very, very important, and though it is picking up, but this is one area which we want to continue to. The revised document of the National Multi-Sectoral Action Plan. We have a multi-sectoral action plan which we prepared, and as a whole of government approach had expired about a year ago, and the team has already prepared the draft document for 2023 to 30, and we will be discussing in the ministry again for launching this. Health promotion and behavior change is also one more area as a whole of government approach, and today is one such example, and management with targeted approach and infrastructure in terms of cancer facilities is also one area in a way of hub and spoke model. And human resources in all spheres, and also using of technology and evidences, etc., and others linkages with other line ministries, which is listed out in the NMAP, and also immunizations in terms of vaccination, etc. Also, and the overall impact of environmental factor, which is little beyond health ministry, but we need to do the advocacy at the highest levels. So this is what I had to give you a glimpse of all what is coming up in the next 2 days. Thank you very much.
Thank you so much, sir, for a very insightful presentation. And ladies and gentlemen, we would like to appreciate Dr. L. Swastisharan, sir. And I would request Shri Krishna Babu, sir, IAS, Special Chief Secretary to Government, Health, Medical and Family Welfare Department, Government of Andhra Pradesh, to kindly join us on stage and kindly present a memento to Dr. L. Swastisharan, sir. Thank you so much, sir. We would request all our respected speakers to kindly stick to the time given. For the smooth flow of the session, we would really appreciate. And proceeding towards our next speaker, it's my honor to introduce our next speaker, Professor Rakesh Sahai, a distinguished expert in the field of endocrinology. He is the professor of endocrinology at Osmania Medical College and the superintendent of Osmania General Hospital in Hyderabad. With years of experience and profound expertise in the management of diabetes and hypertension, Professor Sahai will delve into the critical challenges we face in screening, diagnosing, treating and managing these prevalent non-communicable diseases. Ladies and gentlemen, please put your hands together for welcoming Professor Rakesh Sahai on stage.
A very good afternoon to all of you. And having me here today, and limited time that I have, and in the limited time that I have, I'll try to highlight a couple of important points regarding diabetes management, diabetes screening, management, and the preventive aspects. So we've just heard about the NCDs, about the National Program for Non-Communicable Diseases, and we just saw that diabetes is to the tune of 65 million. This was when this program was initially started. But what I wanted to highlight as the first point is that the burden of NCDs is continuously growing, and we have the data from the ICMR INDIAB study, which was published in 2023, which shows that diabetes prevalence has gone up to about 11.4%, pre-diabetes is 15%, hypertension is 35.5%, and so on and so forth. So this point highlights the fact that the burden of NCDs is continuously growing, and we are fighting against this growing burden of NCDs. And the other important point that I wanted to highlight here is that there is clustering of all these NCDs together, and that's the reason why we have one program which is addressing several of these disorders, because all of them have a common soil which is leading to the development of these disorders, and that is probably one of the factors is insulin resistance, and that is driven by a lot of environmental influences which are driving these burden of NCDs. And as you can see, we are looking at diabetes, which is 101 million, but we have clustering of all the other risk factors, other non-communicable diseases which are coming along with it, and so therefore we need to address. The other important point is that when we're looking at it, when we're looking at the prevalence rates, there are differences in terms of the diagnostic modalities that are used. While we're looking at diabetes, we're looking at the blood sugar levels. There are different ways of diagnosing diabetes. We're looking at the fasting plasma glucose levels, and we all know these levels. I'm not going to speak about the cutoff points, but what I would like to highlight is that we can diagnose diabetes by using the glucose levels. We can use the fasting glucose levels. We can use the casual glucose levels, or the random glucose levels, or what we also call as a 2-hour. Sometimes we may do a oral glucose tolerance, and we may use a 2-hour value, or we may use the HbA1c levels. Using these different values, we may have different numbers coming out of each of these, and sometimes there's a confusion because of this. And as we can see, because the WHO recently came out with a figure on November 13th, they released this figure, a worldwide figure of diabetes, where they said diabetes has crossed 800 million. Country also, they have given a projection for India that India has 220 million people with diabetes. And the reason why they brought this figure was that they've looked at the same study that I have just shown you in the previous slide, but they have looked at HbA1c as the cutoff for diagnosing diabetes. And when they looked at HbA1c, we have fallacies with HbA1c. We all realize that fallacies because we have a lot of prevalence of anemia, and HbA1c is falsely high. And therefore, when you look at HbA1c itself, the prevalence rate of diabetes goes up to about 200 million or 220 million, as was shown in this study. So that is another point that I just wanted to highlight here, that there are different tests and different numbers coming out of different tests that are done. Then the other point that I would like to highlight is that diabetes is diagnosed at a particular point of time, but even many years before the diagnosis of diabetes, the changes that contribute to the development of diabetes have starting off. Like insulin resistance starts off several years before the diagnosis of diabetes, and that insulin resistance actually leads to several other problems which may manifest with all the other diseases, as I'll come to that. And as you're seeing here, the onset of diabetes is here, but the problems have started much earlier. And even in the stage of pre-diabetes, there are a lot of metabolic problems that are going to end up with complications. And so if you look at insulin resistance itself, it is contributed mainly by the growing obesity, physical inactivity, and all these parameters, and the change in our eating habits are all contributing to insulin resistance. And insulin resistance leads to not only to diabetes. Diabetes is later on, but before that, there is a compensatory hyperinsulinemia, or insulin levels are increasing to compensate for the insulin resistance, and that leads to hypertension, lipid abnormalities, and promotion of atherosclerosis that can end up with cardiovascular disease. And diabetes is only one of the manifestations where the blood sugar levels rise only when the insulin levels are not able to rise to the requirement. And so insulin resistance is the common soil which leads to many of these NCDs, as we can see here. Even some of the cancers are related to hyperinsulinemia. So apart from insulin resistance, there are many other factors which are contributing to the development of diabetes. And so what I wanted to highlight here is that there are many different therapies that are available today, all of them addressing the hyperglycemia. And today what we realize is that not one form of medication is enough, but many times we may require a combination of different medications to address these various pathophysiological problems that are contributing to diabetes. And diabetes itself may be silent. Many times we realize that half the people with diabetes are not aware of the fact that they have diabetes. But diabetes is the problems, the complications of diabetes are the major challenge. The retinopathy contributing to blindness, that's the leading cause of blindness today. Diabetic nephropathy is the leading cause of end-stage renal disease. Diabetic neuropathy is leading to a lot of non-traumatic amputations. And then cardiovascular disease is also a consequence of diabetes. So diabetes has become the major feeding factor for contributing to all these problems that we are speaking of today. And then early detection is very important because there's a point of inflection before which we can prevent most of these complications. So it is important that we diagnose diabetes early, and we also have so the early diagnosis is a very important aspect that has to be kept in mind. And the other important fact that I would like to highlight here is that Indians have a little different phenotype as compared to the rest of the world. We tend to develop diabetes much earlier, a decade earlier than the Western population. We tend to have more of abdominal obesity and more of the cardiovascular complications of diabetes. And so we have a unique Indian phenotype, which we call, and the fact that diabetes can lead to a significant reduction in the life expectation if it is not diagnosed and treated appropriately. So if with cardiovascular disease, there's a reduction in life expectation by 12 years. Without even that, there is a reduction in life expectation on the average by 3 years, by 3 to 6 years. And the other important point that I would like to highlight is that diabetes often, there's a rule of halves, which we call, that 50% of the diabetics are not aware that they have diabetes. 50% of them who are. So if we see that the number of people who are actually adequately controlled, it's a small number of less than 10% which are actually being adequately treated. And so there is a huge challenge that we need to address. This is the huge challenge that we need to address. And early treatment is very useful because it is very important in terms of preventing complications. What is the evidence for that? We have evidence from studies like this, the UKPDS study, which has shown that with every 1% reduction in HbA1c, there's a reduction in all the complications significantly. And the other important point that has come out of this huge study, the UKPDS study, was that the earlier that you start treatment, greater the benefit is there, even after several years, even after 30, 40 years. There's a follow-up of the UKPD study says that even after 30 or 40 years, you find that those people who were initially well treated are the ones who are protected from complications even 30 or 40 years down the line. So that highlights the fact that treatment of diabetes should be initiated early, and we can prevent most of the complications of diabetes by initiating treatment early in the course of diabetes. Early intensive treatment with whatever therapy they use, even simple therapies like sulfonylureas and metformin, which are the oldest therapies that are available, that lead to a near lifelong reduction in the risk of death and myocardial infarction if treatment was started early. And this is another piece of evidence showing that they looked at people who could achieve less than 7% in the first year of their diagnosis versus those who could not achieve. And those who could not achieve had at least 60% higher risk of strokes, myocardial infarctions, heart failure, and so on and so forth, showing that if during the first year itself, if you are able to achieve good control, you have a good prevention of diabetes. And the fact that we have an early onset of diabetes is borne out by this study, which this campaign which we did across the country. We did 1 million tests on a single day from the Research Society for Study of Diabetes in India. And in that, we found that when we did these tests, we found that we tend to have a lot of people having diabetes at a lower age group, in the age group of 30 to 34. Even without family history of diabetes, many of them had diabetes, highlighting the fact that it is important to screen early, at a younger age, rather than delaying the screening for diabetes. The fact that even though we know all these points, that treatment of diabetes is effective in terms of preventing complications, the dismal fact is that only about less than 30% of people with diabetes are under control globally, and even in our country, we see a figure which is less than 20%, highlighting the need that better control is required, and we need to start doing this earlier than delaying it. And there are many challenges. There are physician-related challenges, medication-related challenges, patient-related challenges, because patients are not aware of the need for better management of diabetes. And then the other point that I would like to highlight is that the treatment of diabetes is it requires a comprehensive approach, not only looking at the medication, but also looking at changes in the lifestyle, which is going to make a lot of difference. And this is the same changes that are going to address all the non-communicable diseases that we are discussing about today. And choosing the right medication is very important. We have options of different medications available today, and choosing the right medication is important. The other point that has come out of the research in the last few years is that most people require multiple medications. A single medication may not be enough because different pathophysiological problems are contributing, and using a combination therapy, early use of combination therapy is good in terms of preventing complications. So initiating combination therapy early is what has been advocated by most of the societies across the world, medical societies across the world. And finally, I would like to highlight the need for prevention of diabetes, and the important point that I would like to address that the most effective preventive strategy that has been shown till today is lifestyle changes. And this is borne out by different studies which have been done across the globe, and they have all shown that lifestyle changes have scored better than even any of the medications in terms of preventing the progression from pre-diabetes to diabetes. A 58% reduction in progression as compared to 31% obtained with the use of medication like metformin. And if you look at the Indian diabetes prevention study also, this again showed that lifestyle changes are important, but the message that came out was lifestyle did not do as well as in the Western studies. So probably we need to do more in terms of addressing these lifestyle issues in our population, because we could see from this India diabetes prevention study that the reduction in the progression could be to the tune of about 40% with lifestyle changes, and the same happened with metformin also. And finally, I would like to say that I would like to conclude by saying that there are 3 or 4 points that I would like to highlight. One is that early detection of diabetes is important. There are a lot of people who are not detected to have diabetes. The burden of diabetes is increasing. Second point that I would like to highlight is that there is need for change in lifestyle, which is going to address all the burden of NCDs. All the NCDs have a common soil which is fueling this epidemic of NCDs, and we need to address this issue. And early initiation of treatment is going to be effective in terms of providing better benefits in terms of long-term outcomes. With that, I'll conclude. Thank you all.
Thank you so much, sir. And we would like to call upon stage Shri Amit Kataria, sir, IAS, Secretary, Department of Public Health and Family Welfare and Medical Education, Chhattisgarh, to kindly join us on stage and to kindly present the memento to our speaker, Professor Rakesh Sahai, sir. Requesting. May I request Mr. Vijay, sir, to kindly join us on stage to kindly present the memento to Professor Rakesh Sahai, sir. Thank you so much, sir, for a great session. Moving ahead, taking a privilege to introduce our next esteemed speaker, Dr. Anshuman Srivastava. Dr. Srivastava, sir, is an associate professor in the Department of Medicine at the University College of Medical Science, Delhi. With his extensive experience in the field of medicine, he brings a wealth of knowledge on the challenges we face in the screening, diagnosis, treatment, and management of hypertension and diabetes. Dr. Srivastava, sir, will specifically address the complexities surrounding hypertension, a condition that affects millions worldwide. And without any further ado, let's welcome Dr. Anshuman Srivastava, sir, onto the stage for his next session.
Thank you. Good afternoon, everyone. So taking the topic further, I would like to discuss today the challenges in diagnosis, screening, and management of hypertension. So to be brief, what is hypertension? It's a chronic medical condition where blood pressure exceeds the normal limits, and approximately 1.3 billion people across the globe are affected by hypertension, and 300 million from India are affected from hypertension. And it's to around 10 million deaths is attributable to hypertension, and around 1 million deaths in India. So why does these deaths occur? Because it doubles the artery disease, CHF, CKD, and peripheral vascular disease. It has a multifactorial origin. It is epigenetic, as well as environmental factors plays a role in its development. And the saddest part is that patients are not diagnosed at all, or they are undertreated or not treated. So a patient of hypertension is diagnosed in India with a BP of more than 140 systolic and 90 systolic. It is slightly higher than the American guidelines, but here we follow the Ministry of Health guidelines, in which more than 140 by 90 blood pressure is considered to be elevated. And further gradations are also there according to the severity of hypertension. Then coming to the basic challenges that we face are at the level of patients or at the physician level. So what are the challenges the patients face? It is the lack of consistent symptoms, because hypertension has varied symptoms like chest discomfort, chest pain, headache, sometimes nasal bleed. So there's a lack of consistency of symptoms, and patients are sometimes unable to understand or recognize or perceive properly that what exactly is causing these symptoms. They attribute it to gas sometimes when they are having a chest pain. So rather than thinking that the patient might have hypertension, a patient of dyspnea, he would attribute it to a gaseous distension of abdomen. So lack of consistent symptoms and false perception. Then lack of availability of BP measuring apparatus at home, and incorrect technique of measuring of BP. So patients are to be taught that what are the precautions to be taken to exactly how to take BP, how to measure BP, and how to use the equipment properly. So the education part is very important here. And sometimes denial, because many a times even young hypertensives are diagnosed and they are in a denial mode that I cannot have hypertension, मुझे BP नहीं हो सकता. So denial is the major problem, and the fear of lifelong therapy. That is also a major deterrent where the patient actually is afraid of starting the treatment, just that the treatment is going to last forever. So we are all aware of the risk factors. It is modifiable and non-modifiable. So the non-modifiable risk factors are age, gender, genetics, family history. And the modifiable risk factors, the ones which we need to take care of. And if we mitigate those risk factors, we are going to prevent hypertension. So cutting down on alcohol, reducing reducing smoke, reducing the weight, and promoting a good lifestyle with reduced stress, more walking, and incorporating a fruit-based or a DASH diet, which we call as a low salt, low sugar, fruit-based diet. So that is to be promoted, and all the bad habits like smoking and alcohol intake are to be curtailed. So even after prevention, if the patient has hypertension, what is to be done? So early screening is utmost important. So early detection and screening can be done at two levels. One is opportunistic screening. Whenever a person comes who is an adult of more than 18 years of age to any health center, or suppose during college admission, so at that time we the BP, because we should all remember that 20s or 30s are the new 60s. The diseases which we were getting in the 6th decade or the 5th decade, we are getting it now. So to do the opportunistic screening and then a targeted screening. Targeted screening for those who are more than 50 years of age and those who have a family history or who are smokers, obese, or have some other comorbidity like diabetes and insulin resistance. Government's initiatives have been tremendous here. As we know that to screen a disease, it's always better to start from the grassroots. And when we start at the grassroots level and we try to promote good health practices, and we do also told by Dr. L. Swasticharan before. And also, there are many novel approach that the government. So the new India or the Naya Bharat is always in sync with the technology. So all the data that is being generated from the NCD portal, Ayushman Bharat Digital Mission, and the Wellness Center is integrated, and a risk stratification is. And the state-of-art new clinical decision support system has been. What it does, it empowers the paramedics. So a patient presents to a health center, first analyzed by a paramedics, just like it happens in the West. There's a algorithmic-based approach. So the data of the patient is entered over there, and the nurse, the paramedic, fills the data in the portal, and a report is generated. A preliminary treatment report is generated. And based on that, it is sent to a medical officer who who may reject it also, depending on the type of report. And following the national guidelines and the WHO guidelines, a treatment is prescribed to the patient. So it is involving the novel approach that we are having here. Now, how to diagnose hypertension? Diagnosis of hypertension should be based on at least 2 measurements taken in the clinic on at least 2 visits. It's not like that first time a patient presents with a BP of 150/90, say that he's hypertensive. So it should be at least 1 or 4 weeks apart, or we can tell the patient to go for routine blood pressure charting. And he brings with the blood pressure charting. And then after seeing the average BP, average home or ambulatory BP, we can tell the patient is hypertensive. And of course, if the patient is presenting with the hypertensive emergency or urgency, straight away treatment can be started. So the treatment of grade 2 and 3 hypertension patients are to be started straight away, whereas those with grade 1 hypertension who also have some comorbidity is to reduce BP in the age groups of less than 80 years of people by 140/90. That is, the systolic BP should be less than 140 and diastolic should be 90. Same holds true for diabetics, whereas in octogenarians, the range of BP or the target goal of the BP is higher. It is 150/90. Then when the patient is not responding to the treatment, so this is another challenge that the physician faces, resistant hypertension. So what is to be considered in case of resistant hypertension? It could be anxiety, that is white coat hypertension. A patient coming to a clinic and is normally scared that my BP would be raised, so that is white coat hypertension. And normally the home measurements are fine. Then non-adherence to medication or the light medication that we have advised, and suboptimal treatment regimens and inappropriate combinations. Many a times the dosage of the drug is suboptimal, so it leads to inadequate BP control and presence of associated conditions which are unaddressed, like obstructive sleep apnea. Many of the patients who are obese, they have problems sleeping at night, they have disturbed sleep, a lot of snoring, and it leads to a bad daytime BP control. So obstructive sleep apnea is another important condition that is to be taken care of. Then there could be drug interaction, the NSAIDs or the painkillers, they actually is BP, and they also cause renal parenchyma, which can finally lead to Then we have secondary hypertension due to some endocrine causes like Conn's syndrome or pheochromocytoma and coarctation of aorta. So these are to be addressed. And treatment of comorbidities, diabetes, kidney disease, cerebral vascular disease, and disease are to be done. Hypertension, insulin resistance, they are all linked. They are all metabolic disorders, and to treat them in a holistic way is important. And finally, to conclude, I would like to emphasize on the fact that patient education is of paramount importance to tell them about the nature of disease, but can produce life-threatening complications. They need to adopt a lifestyle to reduce cardiovascular risk. Lifelong therapy is useful in preventing adverse effects, and knowledge of target BP controls according to groups. So that is it. Thank you.
Thank you so much, sir. And now, moving ahead, ladies and gentlemen, I would request Mr. Parthasarathi Sen Sharma, sir, Principal Secretary, Uttar Pradesh, to kindly join us on stage and present a memento to our speaker, Dr. Anshuman Srivastava, sir. Can we have a round of applause, ladies and gentlemen, for the great session? Moving ahead, taking the time into consideration, we would be ringing the bell right before the completion of time. 2 minutes after the bell will be given for the speakers. We are really sorry, we apologize from our side, but sticking to time is really important, taking things into consideration. And now, ladies and gentlemen, we now move on to the important session discussing state-specific practice and controls and referral pathways for hypertension and diabetes. And our next speaker will address hypertension in Assam. So ladies and gentlemen, please put your hands together for Executive NHM Director Dr. Manjunath Chaudhary, sir, to kindly join us on stage for talking on the topic hypertension in Assam. Can we have a round of applause? Please put your hands together as we welcome our speaker.
Good afternoon, everyone. Respected ASNMD ma'am and all senior officers and participants from different states here. I am Dr. Manoj Kumar Sururi, Executive Director of National Health Mission Assam. I shall be very brief to give a highlight on what is happening in Assam. In last few years, from 2018 when we started this program, hypertension, we have seen that it has increased to quite an extent, but Government of Assam, with the help and assistance from Government of India, we are trying our level best to control the hypertension in the population, to reach them and to stabilize the whole problem in the state of Assam. If we see the NFHS 5 has shown prevalence of raised blood pressure is to be 19.7% in our state. We have 33 districts in the state, and total screen for hypertension we have done 51,82,349, which is 38%. For in the last year, that is 2024-25, we have done a lot of work which we could not do in last 4 or 5 years. And the 75 by 25 target, which is 10,32,000, we have already done 5,39,421, that is almost 50% we have already completed. Then these are the actually level of care, that is primary care and secondary care. These are certain numbers of hospital and health facilities that we have in our state. Moreover, we also have 13 medical colleges in the state, which I have not written here, but these are the actually facilities, but they are not enough to reach everyone. That is the reason why we are trying with the mobile medical unit, VHOP, and also Assam Cancer Care Foundation is trying to go home to home and trying to control the program. Ma'am, these are actually availability of NCD services. They are screening for hypertension, opportunistic and population-based, diagnosis with support from e-Sanjeevani, and follow-up and regular counseling, dietary advice, etc. That these are normal procedures we are doing in the background. But I like to emphasize that in last 1 or 2 months, we have started one home-to-home visit program in Golaghat district. And this is a pilot project where we have started giving medicine to above 60 patients going home to home. And if we become successful, we'll try to extend to almost all districts in coming 1 to 2 months, we'll start that. So this is one unique step that, ma'am, we have started in our state. And we have been able to reach many people, and we find that if it is successful, then we'll be able to control the whole thing. So these are the activities involved. Very briefly, this is the current status. NPCDCS now in Assam from 2018 with screening of the common NCD initiated with CBSE, screening of all adults more than 30 years of the age for the 4 common diseases, diagnosed patients of hypertension follow-up, and India Hypertension Control Initiative started in 2 districts of Assam, standard treatment protocol for hypertension developed in 2022, protocol drugs being indented regularly. We have done so much of procurement of medicine now, which was not there in last few years. Antihypertensive medicines we have procured. And this is the 53% of one enrolled 30 plus population. Screening, and this one is under treatment. So we have done 24, 25, we have done lot. This I have tried to show in a graphical manner. This, ma'am, you can see that from January 24 and the difference in December 24, we have done lot of work. But this one, in between little bit of work was hampered in September 24, but after that we have been able to do it again. This is the medicine. Amlodipine was in 24-25, this is a very high rise of procurement and distribution. And telmisartan 40 also, we can see here that we have done a lot of procurement and use of these medicines. These are challenges faced actually, but we are trying to reach the population by reaching them, by going to their villages, doing outreach program, giving training, education, IEC, and as I have said that now we have started going to the home for giving medicines to the 60+ population, and we'll be also trying to extend it to the other districts of the state. No clear directive provided on how to link with the tertiary hospitals. This is one challenge, but now we have also discussed with the medical college facilities, and we are trying to make them a direct channel so that we can give specialty care in the medical colleges. And so regular training programs we have undertaken for medical officers, staff nurses, CHOs. Regular district-wise review we are taking. We are doing training programs. We are doing regular drug procurement now, so that there is no stock out. So that also we are taking care. State has initiated a small pilot, which I already have told ma'am, it is in Golaghat district from December 24. And we have seen a rays of hope that this will be a very successful program in our state, ma'am. So these good practices already, actually, ma'am, I have already briefed, so I will not take much time on this. These are the practices like procurement of medicine, doing outreach programs, and also all these training programs for the doctors, nurses, CHOs, etc., which are helping a lot to us. Outreach program, as I already have briefed, ma'am, these are the pictures of the outreach programs. EHOP sessions I have shown. This is Karimganj district, boat clinic in Dhamaji district, boat health services in remote riverine areas with boats. This home delivery practice, ma'am, I have already said. So patients more than 60 years are being provided care at their homes with anti-hypertension, diabetes and hypertension medicines. And control patients are given relief, while those who are found to be not in control are referred to the higher specialty centers. Till date, 167 sessions have been conducted, and with drugs provided to 1,900 hypertensive, 2,200 diabetics, and 1,700 patients with both hypertension and diabetes mellitus. So these are the photo gallery for the Golaghat district that our healthcare providers have gone to house. So thank you, ma'am. This is what is going on.
Thank you so much, sir. We would request you to kindly stay back on stage. May I request Srimati Aradhana Patnaik, ma'am, to kindly join us on stage, Additional Secretary and Mission Director, National Health Mission, Ministry of Health and Family Welfare, to kindly join us on stage and present a memento to our speaker, Dr. Manjunath, sir. Thank you so much, sir, for an insightful presentation. Moving ahead, ladies and gentlemen, our next speaker will shed light on the diabetes control measures and referral pathways specific to state of Rajasthan. Ladies and gentlemen, please put your hands together as we welcome our next speaker, Dr. Bharati Dikshit, MD, National Health Mission, Rajasthan, to kindly join us on stage and present her presentation.
A very good afternoon to respected AFMD madam, respected seniors and colleagues from the ministry and from various states. presentation. The presentations. No, it's not working. The presentation is not working. Till then, I'll just briefly tell about the initiative that we've taken in Rajasthan. We had recently started a pilot project by the name of Mission Madhuhari. So, this pilot is confined to treatment of persons living with type 1 diabetes mellitus. It is a recently initiated pilot project. As per the International Diabetic Federation, it is expected that the state of Rajasthan has 53,000 persons living with type 1 diabetes mellitus. Also, we would like to mention that primarily the two types of insulins that are the treatment of this disease are being already included in the essential drug list of our state. First, we tried to identify the reason. First, I'll try to explain the reason for going ahead with the pilot program. Before the initiation of this pilot, we did extensive scope exercises of what exactly was happening in our public health facilities, the type of patients that were visiting the center, the type of facilities that they were utilizing, and the follow-ups. And few important findings that we discovered were that there was absence of any standardized guideline of care for type 1 diabetes. Different protocols were used by different doctors for different patients. Secondly, the initiation of treatment was quite delayed because children with type 1 diabetes generally land up in public health facilities when they have incidences of diabetic ketoacidosis. So that was quite delayed, and we wanted to have a program wherein we could timely identify them. Thirdly, and most importantly, we did not have a robust monitoring and evaluation program, proper follow-up and referral structure, which needed to be strengthened. And fourthly, there was lack of community awareness about this particular disease. So, keeping in mind all of these things, we started with our Mission Madhuhari. This is a comparative of what exactly we had in our system and what was the further roadmap that we were anticipating, that we were planning. So, if we talk about screening and diagnosis, as I already said, the detection was quite late. In emergency cases, we wish to have the detection right in time before any such incidences happen. Secondly, the insulin therapy that was being used for treatment was primarily pre-mixed insulin, and we wish to change it to basal bolus regimen. Thirdly, the blood glucose monitoring was not proper, was not continuous. It was absent due to high financial burdens, and we wanted to shift it to 5+ tests a day and with continuous glucose monitoring. Fourthly, since the detection is quite late, so there was high possibility of development of complications and comorbidities further later in life. So if the detection happens early with proper monitoring of height, weight, blood pressure, proper fundal photography, thyroid scans, we could have avoided a lot of comorbidities. Next, we also wanted to have proper diabetes education and team care program for this service, for the family members of these children. Till now, we did not have any such program in the state. Target HbA1c level was not identified, was not recorded because of absence of data systems. Now we had targeted it to be between 6.5 to 8.5. And mortality and complications definitely could not be documented properly because of lack of data. Now, with proper data documentation, we could have easily averted them. So this was the way forward and the interventions that we planned. First of all, we formulated and implemented standardized guidelines and protocols for delivery of quality treatment of type 1 diabetes. Secondly, we ensured and strengthen the supply chain of essential commodities for monitoring and treatment. That I shall be explaining it in my further slides. It included the medications, the medication delivery devices, as well as the blood glucose monitoring devices. Thirdly, we established proper monitoring and evaluation systems, follow-up mechanisms, and referral linkages. Counseling of the patient care providers was very important, and we did definitely give a lot of attention to that particular aspect also. And finally, we plan to roll it out as a comprehensive strategy all over the state very soon. The program, the pilot, was launched on 12th of August 2024 by Honorable Health Minister of Rajasthan, Shri Gajendra Singh Khemsar ji. The Clinton Foundation had approached Srimati Padmaja Kumari ji. She is the Princess of Udaipur, and she herself is suffering from this particular ailment. So she partnered with the organization, and along with the government of Rajasthan, we initiated this campaign. We started with 4 districts and 12 health facilities, and capacity building workshops were done extensively for all the healthcare providers in these facilities. We had set up type 1 diabetes NCD clinics and dedicated Fridays as one of the days wherein these particular facilities will mandatorily be holding these clinics. We ensured 3 particular things: ensured readiness of the details, readiness of the staff for treatment of these patients, forecasting of supplies. Though, like we have started line listing of all the patients. So we actually had a due list of all the patients that would be visiting the facility on that particular day. And we ensured that we had back-end preparation of all the medications and devices we would require on that particular day. Thirdly, we also printed and provided proper registers and self-blood glucose monitoring logbooks to these patients. We also provided them with glucometers at home so that they could do regular checkups 5 times a day when required, when suggested and advised, so as to make sure that whatever treatment is being given to them, that is controlling the blood sugar levels properly. Properly trained HROs deputed in these medical facilities. So ultimately, with these services, we had enrollment of a good number of patients, and the consultation and treatment management shifted from the premix insulin to bolus, basal bolus regimen. Education and counseling was done to the caregivers, and supplies of insulin glucometer and test strips was ensured. These were the 3 aspects that we focused primarily on: to have unhindered supply of insulin, both regular and glargine, which is already a part of our essential drug list. Insulin's delivery devices were in adequate numbers as per the requirement, and monitoring commodities, glucometers, glucose strips, lancets, and self-blood glucose monitoring logbooks were given to the patients. With extensive training, we have been able to line list 150 plus patients, and we are, because initially we did our trainings, and now we are focusing on the service delivery. So initial numbers are not very high, but we are rolling out in the rest of the facilities also. We are expecting to at least enroll 1,000 patients by the end of this month and ensure proper services in 60 plus patients. We provide facilities, these glucometers and test strips to them at home. These are the coverages. This initiative was covered by Times of India and in the local media as well. These are the healthcare facility photographs and the medications and insulins that we provide them. This is the second photograph, shows the registers and the logbooks that are given to the patients to be taken at home. Further, we wish to identify, first of all, we are mapping all of these patients, and we are creating a database with the help of Khushi Baby platform. Secondly, trainings, initially we had confined to these 4 districts. Now we wish to further scale it up to the entire state. Linkages with other programs that are already there in the field, like RBSK, RKSK, and Ayushman Bharat school health programs. We'll be linking them very soon, and definitely we will be scaling it up all over the state. Thank you. Ma'am. Ma'am, we are not doing it. We are doing it separately, but we will do. We are engaging Khushi Baby platform. So they are digitizing this data, and thereafter. Ma'am, I was told there are some API issues that we don't get API to integrate with some of our. Yes, ma'am. No, ma'am. We are doing it with same manpower, already existing manpower.
Detailed.
Yes, ma'am. With the same manpower, we would need, ma'am, assistance from NHM because after, like, initially the glucometers, glucose strips, all the purchases we are doing through RMRS. But if we wish to scale it all over the state, then we would need assistance from the NHM. So we would be submitting that proposal in the supplementary PIP also, and we'll request you, ma'am, for that support because it has actually yielded very good results. Though the database right now is not very high.
Under NHM, we are already providing funds for glucometer.
Ma'am, we need 5,000 because as per our calculation, for the glucometer costing around 3,000 and 2,000 for the glucose strips. So if that we extrapolate to approximately 50,000 patients that we have all over the state, the fund requirement would be huge. So even if it's in a phased manner, it could at least make our program evolve over the time. Thank you, ma'am.
Thank you, Dr. Bharti. We would request you to kindly stay back on stage. And requesting very proudly from our own state, that state of Telangana, Secretary to Government Health and Medical Welfare, Dr. Christina Z. Shongtu, to kindly join us on stage to present the memento to our speaker, Dr. Bharti. Can we have a round of applause, ladies and gentlemen? Thank you so much, ma'am. And now moving ahead, ladies and gentlemen, moving towards a crucial session focusing on health promotion and communication activities, specifically looking at the role of community-based intervention in the prevention and control of non-communicable diseases. In this session, we will explore the various strategies, initiatives, and successful models of health promotions that engage communities in tackling non-communicable diseases such as diabetes, hypertension, and other chronic conditions. We are now eagerly ready to hear from our distinguished speakers for this session who will share their expertise and experience in community-driven health promotion. So taking a privilege to introduce our next speaker, Shri Narendra K. Yadav sir, who is the National Ambassador of the Fit India Movement. Shri Yadav sir, an esteemed officer of the Indian Revenue Service, belongs to 2009 batch and has been dedicated advocate for promoting fitness and well-being across the country. As a strong supporter of the Fit India movement, Shri Yadav sir has played a key role in encouraging individuals and communities to adopt healthier lifestyles. His work focuses on inspiring the nation to prioritize physical fitness and wellness, aiming to reduce the burden of non-communicable diseases. Ladies and gentlemen, please put your hands together and welcome Shri Narendra K. Yadav sir for his next session.
Respected senior officers, doctors, ladies and gentlemen, very good evening to all of you. First of all, I would like to express my sincere thanks to NHSRC team for having me here. And before starting, just I want to ask a question. There is an old saying, health is wealth. So I would like to add one more thing in it. Health is the only wealth. How many of you are agreeing with me? Okay, I'm going to give you a scenario. Suppose you are hospitalized and suffering from some disease, and doctors are coming to you and saying there is chances you may recover, you may not recover. Then what you will aspire that time? I think only health. And beyond that, one day, suppose you are sleeping and एक देवदूत आते हैं, messenger of God, और he offers something to you. He offers, I will take all your wealth and I will gift you good health. I think without thinking a second, you will accept the offer. So health is very important part of our life. And if we see, look at another scenario. Suppose we go to office every day, and if we miss, we take a leave or sanctioned leave sort of things, because we fear that we'll get penalized or will attract some penal action. But we don't do exercise, and we don't go for any kind of physical fitness, and we think that it is okay. But things get accumulated. It means after some time, suddenly you will come to know that you are diabetic, you are having some heart disease, or any sort of non-communicable disease. But suppose if you are aware, well aware, and you are doing exercise and some fitness activity on daily basis, then you can remove this problem. Means whatever diseases you are attracting, you can get rid of. So Fit India movement is got launched, got initiated to keeping these things in the mind. Because nowadays, with modernization, these kind of diseases like diabetic, obesity, and heart diseases are increasing day by day. So let's start further. It's me, already introduced. The motto, if we talk about the motto of Fit India, fitness ki dose आधा घंटा रोज. It means you need to do some physical activity at least half an hour in a day. But I would say, अगर आधा घंटा भी नहीं तो 24 minutes per hour 1 minute. At least if you are taking out for yourself, then you can keep yourself fit and healthy. And if we talk about the vision of Fit India mission, it is very clear. Means the physical activity or fitness to make it an integral part of one's life or every citizen's life. So if it would be an integral part, then it means you have adopted this culture of physical fitness. And if we'll further go talk about the mission of Fit India movement is to raise the awareness about fitness, to motivate the citizens for taking responsibility, for doing some physical activity, and beyond that, to create such an environment where one get motivated to do some physical activity. And we will talk about further to get the support of community, to get the support of corporate schools, so that we can get motivation to do some workout. So vision and mission is very much clear of this movement. And further, if we'll go, we'll see the objective. Objective are what is the objective? Objective is also that making people self-aware. If they are self-aware and making people, giving them opportunity, because suppose you want to do workout and you are not getting any space or any places to do some workout or physical activity, that is also means there is one objective that to provide the opportunity. And if we'll go further, so we can see that reduction is also, means your poor habits, your dietary habit, poor dietary habit, to reduce those habits, and further sedentary lifestyle, to reduce the sedentary lifestyle. These are the main objective of Fit India movement. And if we'll go further, key initiatives are very important so that the momentum be started from 2019, keep that momentum. For that, Fit India movement will keep on taking some initiative, like you have seen recently cyclothon, where we are promoting cycle as a mode of transport, even a healthy mode of transport. If you are doing cycling, your health will be better, and there will be no pollution in environment also. So these kind of things, not only this initiative, there are further more initiative like fitness challenges and campaigns, Fit India Freedom Runs, Fit India Cyclothon. I already 30 days fitness challenges. Already time to time, Fit India keep challenging the citizens. You participate in challenges and get a certificate. Means to maintain the momentum of fitness, Fit India keep doing something. And this is the wonderful application of Fit India, where you can count your calorie, where you can count your steps. Even in this application, you can get tips about healthy diets, about exercise. So if you have not downloaded, please download this application. It's a very useful application. And this is also another initiative to bring a corporate in support of Fit India movement. Suppose there are a lot of corporates and small changes in their workplace or environment, such as increasing use the stairs. If they are using stairs, it means there is a reduction in sedentary lifestyle, or standing desk to making the standing desk for in workplace for working, and fitness breaks and health camps. Time to time they are organizing health camps, fitness breaks. So they are doing so many things and supporting Fit India. This is very important, as earlier previous speaker have also emphasized on community engagement. Without a community, without taking responsibility as a community, we cannot make this movement successful. So wherever you are living, suppose in a society, you should promote the sports, you should promote the fitness. At least if you are not having time on weekdays, you may take out time on weekends. So community interest is very important. These are the digital platforms, and putting your selfie, taking out pictures of while you are doing workout or running, and posting on social media, tagging Fit India. This is another way to motivate other citizens who are not doing, the colleague who are not doing any workout or any exercise. You can motivate them by putting your pictures and photos on social media. Impact on society. There is a huge impact on society if you are fit. Suppose you are not having any kind of disease, it means the cost of healthcare will get reduced, and automatically the productivity of a person, the efficiency of a person will increase. So national productivity, it is automatically increased. So need not to explain much on this. We need a physically active and healthy society. We are having some challenges also, like limited awareness in rural areas, and there are infrastructure related issues also we are facing. And these are the future plans, expansion of infrastructure in rural areas as well as in cities, and collaborating with the private sector more, so that we can come out with creation of new fitness programs, new fitness regime. Fit India movement is not just a campaign, but a step towards national culture of fitness. We are trying to integrate physical activity in life as a culture. So non-communicable disease, already we have seen this. So the role of fitness means if you are doing daily physical activity, keeping your diet clean, and small behavior changes, we can combat with these diseases. So we can see a comparison in modern lifestyle. Due to modernization, we are more towards the processed food, and if we see in our past times, we are more towards the physical labor. So we were having more longevity without diseases. Staying healthy is as easy as A, B, C, D. So avoid alcohol, be physically active. I think everybody knows this, just I'm reinforcing. So fitness is not that much hard as we think. You can see the barrier, mental barrier. I want to highlight, I don't have time. When I talk to many officers and persons, simply they have one excuse: I don't have time to for physical activity or physical workout. कितने लोगों को लगता है कि उनके पास टाइम नहीं है? I think if you prioritize the things, suppose if you want to catch a flight for Hyderabad, then you have time to reach on time. Because you see, if you miss the workshop, you may attract something. But you will, if you are missing your workout, you think that you are not getting any penal, but it is getting accumulated, as I told earlier. In coming days, you will get it like a type 2 diabetes or heart disease. So fitness, you cannot miss. Types of exercise I will highlight, like aerobic exercises, where your cardiovascular activities are taking place, means swimming, cycling, skipping rope. And there are another kind of anaerobic exercises, strength training. Strength training is also very important, because if you are having muscles, your metabolic rate will be up, and your aging process will be slows down if you are having muscles, and along with that, your bones density will remain intact. So you should definitely do some strength workout at least twice or thrice in a week. Flexibility exercise is equally important. It increases your mobility as well as your balance in the body. Stress. So I will only line here on stress. We work in office, we work in some other places, and sometimes things go beyond our control, out of control. And we got stressed. We try to control the things, but what I would say, rather controlling the situations and blaming others, just try to find out the solutions. What is the solution? Think about the solution, then you will not have the negative stress. You will have positive stress over you, and that will not harm your health at least. Time management, not to mention, you people are more experienced. Myth versus reality. Yeah, this is very important. Only intense workouts make you fit. No, it is not like that. If you are doing 1 minute of consistent, that is also will improve your. So saying that only you need intense workout, that's not true. Call to action for stakeholders. Self-explained. Fit is not a destination, it is a way of life. So be physically active, eat right, eat healthy, and increase your productivity, and make a culture of fitness in your life, and make India a better place, healthier place. Thank you.
Thank you so much, sir. We request you to kindly stay back on stage. I personally feel this session was more on me, where exercise plays a vital role. So ladies and gentlemen, to present a memento to our speaker, may I request Dr. Saurabh Jain, sir, Joint Secretary, Policy and NCD, to kindly join us on stage and present the memento to our present speaker. Thank you so much, sir. Before we head to our next session, may I take a privilege of announcing, right behind you, you can see a few kiosks where we have the health checkups going on. And to proudly present you, we have the Telangana Diagnostic, first in India, covering up to 33 districts with more than 136 tests are being done over here, the blood tests. So requesting whenever you get the time or you are about to leave, we request you to kindly join the Telangana Diagnostic kiosk and give your blood samples. The reports will be sent to you and the physical reports can be collected tomorrow. Thank you so much. And as we proceed for our next speaker, Shri Balu Naik sir, the Deputy Director at the Food Safety and Standard Authority of India, based in Hyderabad. Shri Naik sir is a key figure in the Eat Right India movement, a national initiative aimed at promoting healthy eating habits and ensuring food safety across the country. The need of the hour is mentioned over here. His work with the Food Safety and Standard Authority of India has been instrumentally in raising awareness about importance of making healthier food choices, preventing lifestyle-related diseases, and fostering a culture of food safety. Shri Naik sir will share a valuable insight into how the Eat Right India movement is shaping the future of nutrition and public health in our country. Please put your hands together and welcome Shri Balu Naik sir on stage.
Good evening, honorable guests and senior officers. From the FSSI point of view, I just want to cover one of the initiatives of FSSI, how FSSI works from central and state level. Central FSSI deals with majorly deals with the standards, framing of the standards and regulating the food safety, storage, transportation every way, and export, import. What the state FSI deals with the enforcement activity. So I'm covering now the initiatives of the FSSI, how FSI is inculcating the habits to transform the nation food habits to healthy habits. FSSI is the apex regulatory body of India. It's an autonomous body under Ministry of Health and Family Welfare. Our main aim is to protect the public health, ensuring the safe food, how we are ensuring the safe food. Mainly the framing standards. All over India, we have more than 200 top premier institute scientists. They will be framing the standards for various food products in India, what we are having today. So our mandate is to ensure safe food, how we are ensuring the safe food. Before coming to here, I went to the kitchen of this resort. I was surprised, really, we had the safe food. I gone through all the reports. What are the water report they have gone tested or before day. So I checked it through. They had the training for FASTag, food safety compliance training for all food handlers. Even they had the vaccination record of all the food handlers who are preparing the foods. So not only the manufacturing units, ready to eat food also, restaurants, all are taking care of the regulatory framework and they are following the system. So not only that, the government, state government, Telangana, you're seeing that I thank to the government authorities. They daily will find in social media news, wherever the inspections, raids on Twitter and social media. So it's very proactive, not only Telangana, many states are performing well in transforming the food habits. So I don't want to go through all my senior. So these are the initiatives of the FSSI, Eat Right India, Fortified Food, RUCO, Aaj Se Thoda Kam, Clean Street Food Hub, Save Food Share, Diet for Life, Eat Right Mela, Food Safety on Wheels, promotion of millets. Eat Right India started in the year 2018. with 3 pillars: eat safe, eat sustainable, eat healthy. How we are making the eat right? So first thing is, we are giving training to each food handlers, even a street food vendor also. Mandatorily, any street food vendor, whether it is a small street food vendor, whether it is a hotel or whether it is some holy place or something, everybody should have the license of the food safety. Without the license, nobody is right to do their activity. So FSSI has mandated that every street vendor should have the license. Without license, they cannot operate. So how we are doing that one? Eat safe food. So we are giving training and we are conducting testing for the street vendors. Suppose that using the water, some petty food business operator is using the water. So we are testing that one also. Government of India, FSI is supporting the labs to give the infrastructure to each state. So all the states are, now FSI has given mandatory to have the labs, local government labs in each state. So eat healthy habits, how we are promoting healthy habits. Front pack labeling, already our scientific committee is working on that one. If the front pack labeling is having the informed choice, suppose high fat, high sugar, high salt. So if informed choice can be given to the public, they will choose the better product. So this is one of the initiative of the FSI in Eat Right India and Eat Sustainable. What we are advocating to the public is that eat local, eat seasonal, eat sustainable. It eventually develops the healthy habits to the, now in this program, every day, even the state government also conducting awareness program to the schools, colleges, and all the campuses. So in that, we are promoting local food. Local food definitely emphasizes, definitely, it will make the public to have the healthy food. So Eat Right Campus. What is the Eat Right Campus? Suppose we are not giving just a certificate. In any campus, we are promoting Eat Right Campus means we will conduct the pre-audit based on the ingredients they are using. Suppose any ingredients they are using, they are not tested that ingredients, or they are not having some millets in the campus. Use of millets. Local millets definitely will improve the food habits and reduce the NCDs. Suppose if you take the ragi, I thank the government, some of the state governments in PDS system, they have provided. I thank Krishna Babu sir for providing the PDS system, especially for the PDS system with the millets. Really great initiative of the government, state governments are working very good to promote the healthy food habits, even the fortification also. So in each campus, we are testing ingredients and we are conducting audit. Not only the FSSAI officers, even the third-party audit will be conducted by the concerned agency, and after that only, we will be giving the training to the food handlers. After food handlers training, final audit will be done. Based on that, we are giving. It's not just certificate, it is the inculcating the habits to have a healthy food. The Telangana government and all the governments has achieved maximum targets in Eat Right campuses. It will definitely impact this, reducing the NCDs. So trans fat eliminations, we have achieved less than 2% trans fat. So our target is to make the trans fat 0% in the processed food also. So in every, in a today kitchen, we have this polar meter to test the trans fat polar compounds in oil. Suppose if you use any edible oil more than 3 times, there the polar compounds will increase. Definitely if the polar compound increases, it will causes the NCD diseases. So in every, how we are making, FSI making these hotels and restaurants is that every hotel or restaurant should have this testing meter, polar compound testing meters, where the polar compounds, polar trans fat should not cross the 2%. That is 25% of the polar compound, it should not cross. So in each kitchen, we are promoting that they should have the polar meter. So food fortification, it is one of the best method to tackle the anemia and other NCDs, especially in PDS, public distribution system. All the rice, all the major staple cereals we are getting with the fortified rice. Fortified rice, fortified wheat, even the staples, even the manufacturing units, mandatorily we have made that for cereals and milk, oils. Mandatorily they have fortified with vitamins and micronutrients. Swasth Bharat Yatra, this is one of the yatra organized by the FSI to conduct the awareness at national level, where we have crossed more than 21,000 kilometers. This one rally program, various states has conducted, and the government of India also supported for this program to raise awareness and what is the healthy food and what is the better nutrition food, what is. So this is the one of the Aaj Se Thoda Kam campaign, where low sugar, low fat, low salt. So in schools also, we are making that in every school they should not have any shop which is having highly processed food. We are ensuring that the schools should have minimum 100-meter distance from their premises. We have encouraged all the schools to have local food, not the processed food. Why we should not have the processed food means there is a loss. When we process the food at high levels, there is a loss of micronutrients. That's why the FSI is encouraging having the local food, eat local, eat sustainable. RUCO is an initiative regarding the oils. Suppose this canteen is using the oil more than 3 times, we are monitoring. How the FSI is monitoring is, the FSI is giving to the aggregator. Suppose 2 times used oil, they will be using for the biodiesel conversion. So these canteen will be giving to the aggregators, where the FSI is monitoring with the aggregators. Those authorized aggregator can take from here. Suppose the oil cost is more than 150. The aggregator take the reused oil for more than 70 rupees. So the restaurant or the hotel agency will get benefited. At the same time, we can ensure that the polar compounds will be less. So this is the way how the FSI using this RUCO program to eliminate degraded cooking oil. Even for street vendors also, if state governments are ensuring that every street vendors they are checking, they are making, we are conducting training with the street vendors to give that reused oil to the RUCO aggregator. So ultimately, we can trace out where it is going, whether they are selling locally or suppose if any street vendor is using this reused oil, if our food safety inspector daily they are going to the market and they'll lift the sample. If their sample, suppose RUCO oil they are using the polar compounds is more than 25%, definitely we will take the sample and accordingly we will do the adjudication process, they will be penalized. So this is front pack labeling. It's under working of a committee. So if the front pack label is there, we can give the informed choices. FSI already working on that. Its decision is yet to finalize. So this would be one of the great choices for the consumers. Save food and share food. Suppose somewhere some function is done there, there is some already leftover ingredients which are suppose healthy food or some good food. That you can give it to the Save Food and Share Food aggregator. They will give it to the local NGO or the authorized person. They will not misuse that one. They are registered in FSI website for the Share Food and Save Food. So that we can give to the leftover foods. If it is hygienic, that food also will be tested. So clean seed hubs initiatives. In each district, we are conducting awareness program for the street vendors to have healthy and hygiene food. What is the process to make the healthy food? How, suppose some street vendor is having some transmitted disease, he is using means, we will test all FSIs testing the street food vendors health checkup also. So in that way, we are giving training to them, and we are bringing into the ambient of FSI. So all over India, with the help of NHM also, FSI is technically supporting for the Clean Street Hub. In every district, we will be having one Clean Street Hub. Not only Clean Street Hub, every street, whatever the street food vendors are there, FSI is targeting clean street food vendors, and we have trained more than 2 lakh clean street food vendors. These are the activities FSI has done. So, not only that, if you have any product, suppose if you feel that if your product is some low quality or something, you can give a complaint. Anybody can give a complaint on fast course where the FSI number or the location. You need not to give your number. Immediately, FSI is taking action. In Telangana, as far as central licensing, we have dispersed all the grievances within 24 hours with less number of, even the state government also doing well. They are also daily there, if you give a complaint on social media also, we are taking the complaint, we will inspect the unit, and we are conducting as much as possible to the public to ensuring the safe food. Thank you, one and all. These are the activities. Because of lack of time, I just want to close this one. So these are the FSI. Not only that, FSSI has prepared standards, millets. Nowhere in the world millet standards. We have given the millet standards. Honorable Madam also participated in that one. And I thank Madam to support the FSI and everybody. Thank you, one and all.
Thank you so much, sir. We request you to kindly stay back on stage, and requesting Dr. Brinda, MD, National Health Ministry, Orissa, to kindly join us on stage and present the memento to Shri Balu Naik, sir. Requesting sir to kindly present the memento. Thank you so much, sir. Moving ahead, ladies and gentlemen, taking the privilege of introducing our next speaker, Dr. A. Raghu, sir, the Deputy Director General in the Ayush Division of the Directorate General of Health Service, Ministry of Health and Family Welfare, Government of India. Dr. Raghu has been at the forefront of promoting yoga and wellness activities as an integral component in the prevention of non-communicable diseases. His expertise in Ayurveda, yoga, and other traditional wellness practices has been instrumental in shaping national health initiatives that encourage the adoption of holistic approach to health. So, ladies and gentlemen, without any further ado, may I request Dr. A. Raghu sir to kindly join us on stage and present his presentation.
Thank you, dignitaries and eminent participants. Warm good evening. At the outset, I would like to mention that the traditional medical systems, particularly yoga, Ayurveda, and other systems of medicine which actually prevail in the country, have a great role as far as non-communicable disease is concerned. National Health Policy 2017, if we specifically see, there are very specific policy directives in the care, where the service, it recommends the co-location, integration of Indian medicines to achieve the universal health, accessible, affordable healthcare services. Specifically in the context of the non-communicable diseases, you can see 4.6 very specifically mentioned developing protocol for mainstreaming of Ayush as an integrated medical care. So with this objective, actually, there is a convergence, there is a co-location of the healthcare facilities in the public health facility, primary health centers, community health centers, district hospitals, and even in Ayushman Arogya Mandir, which have been developed by the Ministry of Health and Family Welfare, as well as the Ministry of Ayush, specifically the strengths of Ayush has been integrated. The I would like to draw your attention to a specific survey which was conducted by National Sample Survey Organizations in the 2022-23, wherein very specifically it indicates that about 95% of the rural and urban, 96% of the urban populations are aware about the traditional system. There is no wonder on that. But we will say that 48% of the urban population as well as 45% of the rural population, they use the traditional medicine for rejuvenation, as well as even for 26 and 28% of the population for the therapeutic purpose. And as far as yoga is concerned, very clearly they mentioned that 86 lakh of the rural and 1.1 crore of the population households are specifically using pranayama. Then 70 lakh rural population is using the asanas. So this gives an important pathway for us to think about that, how to expand the scope of this usage of the yoga in our public health facilities and even at the household level. So why it is required, basically, if we want to see that when we analyze the causal pathway of the non-communicable diseases, as the behavior patterns are concerned, the tobacco use, unhealthy diet, physical inactivity, alcohol use, very well mentioned in previous speakers, as far as the biological risk factors, which actually later turn into the biological risk factors into the overweight, obesity, raised blood pressure, raised blood glucose, and abnormal blood lipids, and which eventually leads to various kinds of non-communicable. Simultaneously, which actually the triggering factors of the environmental factors, globalization, urbanizations, and the social determinants of the poverty, low education, and strengths. So where the yoga and other traditional systems are fit into this, this breaking of these kinds of vicious cycle. So there are a lot of studies as far as the specific usage of the yoga and other traditional systems are concerned, which I would like to highlight. One of the things is very study which very clearly mentioned that more than 1 in 2 older adults aged more than 45 years in India without an established history of diabetes or hypertension have 4 or more NCD-related risk factors which accentuate the NCD risk. And our lifestyle, genetics, and environment influence our susceptibility to various diseases in India. Non-communicable illness and injuries are responsible for now the fatality is also increasing. So in this context, yoga as an adjunctive therapy is superior to standard therapy alone in reducing the symptomatic burden and improving the quality of life in patients with recurrent vasovagal syncope. This is one study reported. Another study very specifically mentioned that yoga is not only a cost-effective, but also a feasible form of exercise for individuals of all ages, whether it is a adolescent age group or younger populations or an old age persons also. Very tailor-made yoga modules are available, and that can be easily trained to our population. Efficient adjuvant in reducing arrhythmia burden in patients with the PAF, ventricular tachyarrhythmia and palpitation, in reducing BP, HR, and anxiety and depression scores, and improving some aspects of health-related QOL, specifically mental health. That is also reported in some studies. As far as 10-week, 1-hour sessions of Hatha Yoga resulted in improvement in the stress, anxiety, and health status compared to relaxation. Common yoga protocol. Ministry of Ayush has widely propagated the common yoga protocol, not only in the International Day of Yoga and even various platforms, social platforms. This yoga protocol has now became popular. So the study on yoga protocol clearly indicated that it improved the metabolic and physiological process in the yoga intervention group, which reduced the lipid profile. Yogic breathing exercise improves the diffusion capacity. One study reports very specifically they are beneficial to COPD patients and they can be used as an adjunct therapy with the conventional medical therapy. And another study says that research suggests that the patients with the CKD can derive particularly the quality of life along with the conventional interventions. Yoga, if you make an add-on interventions, the quality of life, particularly the stress reduction and physical functioning improvement is noticed. So along with that, the dietary practices of the Ayurveda, particularly the Dinacharya and Ritucharya for the lifestyle modification is also found to be beneficial as reported by various studies. Pioneering study evaluates daily Ayurvedic practices and quality of life among Brazilian healthcare professionals using WHO, QOL, BRAF, Ahara, Nidra, Vyayama, like that context. As far as the quality of life improvement, Ayurveda medication along with the lifestyle management and yoga effectively controls systolic and diastolic blood pressure and further helps in reducing discontinuation of dose of conventional medicines in essential hypertension patients. Similarly, systematic reviews of clinical trials have demonstrated effectiveness of safety of Ayurveda for managing NCDs. So it is not the lack of evidences, it is the lack of understanding and awareness in our community that is actually hindering as far as the propagation of this traditional medicine, particularly in the context of the NCDs. So as far as in all these components of wellness are concerned, there are very potent role for the additional inputs of the traditional medicine, particularly yoga, in the context of the wellness, where even for the positive parenting for the adolescent health through the Sadvrita and the Achara Rasayana, as indicated in the Ayurveda, the Dinacharya and Ritucharya, and management of even substance use disorders also, appropriate integration of the traditional medicine can be beneficial. So as far as our national programs are concerned, we have actually under the Ayushman Arogya Mandir, defined roles has been given for the wellness activities, even the house visits by the Ashas and MPW, as well as the community level wellness interventions are also very clearly the group counseling and integration of the wellness in calendar health days, outreach yoga camps, and promotion of the cycling, wellness promotion, and wellness interventions at the Ayushman Arogya Mandir by the CHOs and yoga instructors, and even for the school outreach activities. Actually, in all such platforms, yoga can be appropriately integrated. And one study which was conducted under the able guidance of Sasujaran sir, actually, which NPCDCS integration with Ayush, which was done in 6 states of the country, has eventually resulted in the appropriate level of additional improvement in those patients who are actually coming in the target area. And accordingly, one publication has also been made into that. Then, as far as the Ayush Wellness Centers are concerned, Ayushman Arogya Mandirs are concerned, we have clearly at every level, all the functionaries has been appropriately oriented towards the dissemination of the daily practices, seasonal regimen, and yoga to the community. And we have also published certain guidelines for the community health officers, and that is why you can see that over a period of last 3 to 4 years, there is a substantial increase in the patient footfalls of the Ayushman Arogya Mandir, which has been already operationalized through the states within the Ministry of Ayush. Then these are the parallel initiatives which was taken by the Ministry of Ayush, specifically, for example, the school health program, Ayurvidya, Ayush Gram, Yoga Wellness Centers, Vayomitra, Ayush Geriatric Camps, and other things, which support in the NCD prevention and even the management. So no need to tell about the Y-Break and the Yam Yoga. So these are the larger initiative which needs to be propagated. And in a way forward, I would like to mention that integration of NCD, this Ayush into all the NCD units may be one of the desired thing, particularly Ayurveda. The strength of the Ayurveda and yoga can be very well assigned to that. And there is a further research and evidence generation is also required. Then training of the healthcare providers in Ayurveda and yoga techniques will ensure their effective implementation. Then public awareness and education, as well as collaborative approach for foster collaboration between traditional practitioners and modern healthcare providers to create multidisciplinary approach. Thank you very much.
Thank you so much, sir. We will request you to kindly stay back on stage. Ladies and gentlemen, may I now request Srimati Vagati Karuna Garu, MD, National Health Ministry, Andhra Pradesh, to kindly join us on stage and present the memento to our speaker, Dr. A. Raghu, sir. Thank you so much, sir. Thank you. And moving ahead, taking an honor to introduce our next speaker, Dr. Parul Mrugapuri, Associate Professor at the Vallabhbhai Patel Chest Institute, University of Delhi. Dr. Mrugapuri is an expert in the field of pulmonary medicine and a strong advocate for tobacco control. She has been actively involved in the tobacco-free youth campaign and the development of cessation centers, which aims to combat the harmful effect of tobacco use. And ladies and gentlemen, please put your hands together as we welcome Dr. Parul Mrugapuri to kindly join us on stage and discuss the crucial role of tobacco cessation in improving public health.
So a very good evening to all. I'll be speaking on the role of tobacco cessation in the control of the non-communicable diseases. We have been seeing this figure quite often since the program started. So it emphasizes on the fact that NCDs are responsible for a number of deaths. But what I would like to emphasize here is most of the NCDs are strongly associated with certain modifiable risk factors. The word important here is modifiable. And one of the most important out of them is tobacco use, whether smoking or smokeless, something that we can modify. So, some facts about the tobacco smoking. There are 1.3 billion smokers in the world today, and tobacco kills more than 8 million people. There are almost 267 million tobacco users in India itself. And more than 3,200 children and teens under 18 years smoke their first cigarette. That is a sad state of affair. Now, why the youth campaign? Why is the government trying to emphasize on the youth campaign? So the youth is slightly different than the adults. One is the Global Youth Tobacco Survey told us, though the current tobacco users among the youth is decreasing, it is still 8.5%. The youth are different. They are a bit different from the adults. The factors that contribute to the smoking initiation in our youth is the access to the tobacco and certain environmental risk factor. If I go into a little detail, the environment here is the exposure to the tobacco marketing. The X is the price. Because once they initiate, they are the ones who are going to become the adult smokers. The other contributing factors are the community factors, the type of environment they are growing up, what are the tobacco norms, are their parents smoking, are their siblings smoking. These all contribute for them to get converted into adult smokers. And others are obviously the psychological factors like peer pressure. So the youth is very, very important because they are vulnerable. The youth may become dependent even before they know because they are more sensitive to the rewarding effects of nicotine. They become dependent very, very easily. Dependence precedes daily smoking. If we talk about the risk factors of smoking, it influences right from your hair to the tip of our toes. If we talk of cancers, we have cancers of the head, neck. We have cancers of the head, neck, lung cancer, leukemia. We have cancers of stomach, kidney, pancreas, colon, bladder, and cervix. We talk of chronic diseases, and smoking is a risk factor for each and every one of them. The benefits of quitting start within 20 minutes of quitting. However, the risk of heart attack falls to the same person as a non-smoker only after 10 to 15 years of quitting. For the smoking cessation, we have various methods. The oldest one was the cold turkey method, just leave smoking. Don't touch it. Now we have counseling, medications, and the combined approaches. Among the non-pharmacological, the relevant ones are the clinical and the public health interventions. We are here to discuss about the community health, the public health interventions, which include the community-level interventions, workplace interventions, multimedia campaigns, and public smoking bans. And our government has been working hard on all of these aspects. To start, we have bans and the initiatives from the side of the government. Among the community-level interventions, most of them have shown varied improvements in the quit rates. If we see, there have been certain landmark events or the initiatives that has been taken up by the government. In the 1990s, the central government issues directive for prohibiting smoking in public spaces, banned tobacco advertisement in the national radio and TV. The Ministry of Railways banned sales of cigarette and BDs on railway platforms and in trains in 1999. The Supreme Court of India mandated a ban on smoking in public spaces in 2001. The cigarette and the other tobacco products, prohibition of advertisement and regulation of trade and commerce, production, supply, distribution, properly known as the COPTA Act, was issued in 2003, and the National Tobacco Control Program came into existence in 2007. There is now a ban on smoking in public spaces, ban on direct and indirect advertising of smoking products, ban on sales to minors, and tobacco products cannot be sold within 100 yards of educational institutions. This is what is helping in reducing the exposure of the youth to tobacco products. Another initiative by the government is the M-Cessation program that is using the mobile technology for tobacco cessation. In 2012, ban on gutka and smokeless tobacco was issued, and in 2019, the ban on e-cigarettes was issued. A word about the National Tobacco Quitline Services. That is an initiative of Ministry of Health and Family Welfare that was established at Vallabhbhai Patel Chest Institute. It works on all the days of the week except Mondays from 8 a.m. to 8 p.m. And now the services has been expanded to the regional satellite centers, and counseling is now available at regional centers of Guwahati, Bangalore, and Mumbai. We help at the National Tobacco Quitline Services. It is basically a proactive quitline service. Whenever a call is made by a quitter or a person who wants to quit, a quit date is set, and then a pre-quit call is made, a quit date call is made, and then ongoing calls are made to support depending upon the assessment of the condition of the quitter. This is the data from the National Tobacco Quitline Services. Here, we can have a look that we are giving an abstinence rate of around 30%. Now, there are tobacco cessation clinics or centers across country. Tobacco cessation centers are established in the dental colleges. They are established in the various medical colleges linked with the NMC. There are now more than 2,000 tobacco cessation centers, 675 TCCs under NTCP, 607 other than NTCP, and 700 plus in various medical colleges. This is the current status of the tobacco cessation services in India. Another initiative by the government of India is the Ayushman Arogya Mandir. And now we have Ayushman Arogya Mandirs functional that are established across the country. The tobacco-free youth campaign first was started on 31st May 2023, primarily with the aim to raise public awareness, promote establishment of the tobacco-free institutions, strengthen enforcement of the COPTA Act, and create tobacco-free villages, and was a huge success. Tobacco-free youth campaign 2.0 is the second edition that was launched in the Lady Hardinge Medical College, and the Ministry of Health and Family Welfare, in collaboration with the NMC, inaugurated the establishment of tobacco cessation centers in all the medical colleges across India. It again prioritized on increasing the public awareness, improvising compliance, strengthening and enforcement of the COPTA Act, promoting villages, and boosting social media outreach. It focused on the educational material, establishment of tobacco-free villages, and tobacco-free youth campaign also emphasized the whole of government, that is the collaboration of the various ministries. That's all from my side. At the end, I would like to say is that each and every person can become a tobacco cessation clinic in themselves. All you need is just a motivation and a passion to stop other person from smoking. Thank you.
Thank you so much, ma'am. We would request you to kindly stay back on stage, and requesting Mr. Abu Imran, sir, MD, National Health Ministry, Jharkhand, to kindly join us on stage and present the memento to Parul ma'am. We would request Abu Imran, sir, to kindly join us on stage to present the memento. Requesting Dr. Kotwal, sir, to kindly present the memento. Thank you so much, ma'am, for that wonderful session. Taking it ahead, ladies and gentlemen, may I introduce our next speaker, Dr. Sumit Rana, sir, a distinguished professor and a consultant child and adolescent psychiatrist at the Department of Psychiatry and the Drug De-Addiction Center at Lady Hardinge Medical College and Associated Hospital, New Delhi. Dr. Rana has extensively experience in the field of psychiatry, particularly in addressing tobacco, de-addiction, alcohol, and substance abuse. So ladies and gentlemen, please join in welcoming Dr. Sumit Rana sir as he speaks on the crucial issues of tobacco de-addiction, alcohol and substance abuse.
So good evening, everyone. I know you all are eager for the tea break, so I won't take much of your time and I'll rush through the presentation. But this is an important one because all the major risk factors of non-communicable diseases begins with tobacco and drug use. My dear colleague, Dr. Parul covered the tobacco use comprehensively. I won't be touching this part, but I'll be covering alcohol and other drug use disorders. But there are two other risk factors, behavioral risk factors, which is covered by my colleague through Fit India movement, that is insufficient physical activity, and Eat Right India movement. Both of these are covered. Now we must be thinking, when such a great initiative has been taken by the government, why are people still having non-communicable diseases? Such a sort of awareness program is being held. So if you carefully analyze these four things, there is one thing common, and that is the problem with the underlying decision-making system, which focuses more on the immediate gratification, immediate pleasure-seeking behavior, rather than taking care of the long-term happiness and long-term health. But we'll touch this later on. But first, we'll go on to the direct toxic effect of drugs and alcohol on body, which leads to direct damage through blood vessels, leads to hypertension, atherosclerosis, hepatitis, alcoholic cirrhosis, pancreatitis and diabetic changes and kidney damage. Other drugs the damage depends on the method of use. Opioids are used to change the pattern where the foil is taken and the vapors are inhaled by the person, which leads to direct toxic effect on the lungs, leading to fibrosis and other effects. Heart problem and neurological effects are also part of that. But what is this decision-making apparatus which is creating a sort of interest in everyone? One is immediate pleasure and gratification is important. See, we all have enjoyed our share of pleasure, we know it. Whether it is through sightseeing and all, eating great tasty food, enjoying on and off alcohol. So I won't be going into the controversies, but we have all enjoyed the pleasures. But these are also enjoyed by the animals, which differentiate humans from animals. And that is, we are able to take care of the long-term consequences. We are able to enjoy, we are able to indulge in all these pleasures while taking care of the long-term consequences. What happens when a person is using drugs or alcohol is that they are intensely pleasurable and it bypasses all the five senses, right? A person who was described in Gita as a sthit pragya, जो अपने इंद्रियों को नियंत्रित रखे, जो उन पर अपनी चेतना का अंकुश लगाकर उन्हें कर्मोन्मुख करे, उन्हें कर्म की दिशा दिखाए, वही श्रेष्ठ है, वही स्थित प्रज्ञ है. That sage starts having pleasurable stimulus from apart from five senses, and that leads to positive reinforcement much more than our five senses can give pleasure to us, and that leads to craving. But the bad thing is, sooner than later, it becomes the human mind becomes tolerant to the drugs. So the same amount of drug is not able to produce the same amount of pleasure. And that leads to problem, negative reinforcement, because if the person is not taking that drug or alcohol, he is not able to relax. And as soon as the drug or alcohol is consumed, there is a sigh of relief, there is a great relief. That is negative reinforcement. That is an even difficult sort of craving to deal with. But even more than that is, we discussed about the brain system, which takes care of the long-term effect of our decision and actions. Drugs and alcohol have a direct neurotoxic effect on the prefrontal cortex neurons, which leads to problematic decision-making. And the whole executive functioning and the decision-making apparatus of the brain, which was supposed to take care of the long-term consequences, get damaged, and the individual becomes like a person described in Gita like a river. नशा करने वाला इंसान उस नदी की भांति है जिसे व्याकुलता ले जाती है, लेकिन उसे अपने मार्ग का ज्ञान नहीं होता. वो अंधाधुंध बही जाती है क्योंकि वो बहन कर्म संपत्ति. That person keeps on wandering and They are just to seek pleasure, whether it is out of drugs, whether it is out of aggression, whether it is out of many other things like unhealthy diet, physical activity. Despite knowing that they are to have drastic long-term adverse consequences, the person is not able to control it because there is a damage to the executive function of the decision-making apparatus of the brain. It is coupled with poor stress tolerance and poor focus on work, relationship, etc. Apart from the non-communicable disease, they are also exposed to various communicable and other risk factors, including rash driving, IV use, and unprotected sexual activity. The common final outcome, we are talking about NCDs. It is behavioral effect of drugs combined with direct physiological effect leads to non-communicable diseases. Coupled with poor occupational consistency leads to the person stops being an asset to the nation at a prime age. And that is a wasted demographic dividend to the nation. We have to address it. The solution is there, but it is not easy. And we have to use a multi-pronged approach. First and foremost is prevention and mitigation of physiological and psychological effect of alcohol and other drugs. And there are numerous programs run by Government of India, including drug de-addiction program, Nasha Mukt Bharat Abhiyan is also there. Recently, mental, neurological, and drug use, substance use disorder are covered in Ayushman Arogya Mandir scheme, and which can have a dramatic influence on the reach and effectiveness of these interventions. The second intervention that we have to ensure is, apart from screening and treatment, is strengthening the decision-making apparatus of brain. Now, we all have been doing IEC and behavioral change communication strategies through NPNCD has been leading these activities in collaboration with Ayushman Arogya Mandir. But apart from that, we just heard our colleagues that Fit India movement and Eat Right India movement is also more or less aimed towards strengthening this thing. I would like to add on to it that if we can address these things at the childhood through school mental health program or through parenting techniques and all, we can have a much better decision-making apparatus in brain, which can help us in drug abuse in adulthood also. Focus on providing integrative healthcare services, including Ayush alongside modern medicine. Now, allopathy has been traditionally seen by Indian population as a curative thing. But in terms of preventive thing, the traditional healthcare practices are considered better than allopathy. So it will be best if we can collaborate, if we can work with them and for the prevention of these drug de-addiction activities. It emphasizes on the lifestyle changes, preventive care, and neutral treatment methods. NPNCD is envisioned to get intricately linked to the Mandir for screening and early detection, awareness campaign, lifestyle modification, and overall improvement of the mental, emotional, and spiritual health, which is part of the WHO health definition, not just the physical health. To conclude, tobacco, alcohol, drugs are important behavioral risk factors for NCDs. Apart from direct physiological effect, indirect psychological effects through alteration decision-making apparatus of brain plays a big role, result in adoption of unhealthy lifestyle, and it leads to wasted demographic dividend. And through prevention and mitigation of physiological and psychological effects through is the backbone of prevention of NCDs. Health promotion through IAC and behavioral change communication activities can have a dramatic impact. And treatment, of course, can be through Ayushman Arogya Mandir, drug de-addiction program, and Nasha Mukt Bharat Abhiyan. With this, I conclude my presentation. Thank you.
Thank you so much, sir. Request you kindly stay back on stage, and now requesting Mr. Abu Imran sir, MD, National Health Ministry, Jharkhand, to kindly join us on stage and present the memento. Dr. Sumit Rana sir. Thank you so much, sir, for that wonderful session. And a quick wrap. We now move on to the important segment focusing on the state-specific practice in the fight against tobacco use and addiction. The session will highlight the initiative taken in Nagaland regarding tobacco cessation centers and de-addiction centers. Nagaland, known for its rich culture diversity, has also made significant strides in addressing the raising concerns of tobacco use and substance abuse. These initiatives are essentially in empowering individuals to overcome addiction and lead healthier lives. We are now going to delve into the successful models and practice from Nagaland that have contributed to reducing tobacco-related harms. And to hear from the speaker, may I request Dr. Aku Sohia Sir, MD NHM, Nagaland, to kindly join us on stage for the presentation.
Good evening, everyone, respected madam, sirs. I will be presenting on the state-specific practices on tobacco cessation centers and de-addiction centers in Nagaland on behalf of NHM, Health and Family Welfare, Nagaland. Next. Greetings from Nagaland. Next. Next. Next, please. So this slide shows the prevalence of the current tobacco use in Nagaland as per the DAY-1 and DAY-2. Indicating the slide indicating the decreasing prevalence rate in the state. However, as per the GYTS4, that is the Global Youth Tobacco Survey 4, Nagaland is reported to be the second highest in the country in terms of tobacco use, next to Mizoram and Arunachal Pradesh, with a percentage 42.6% as against national average of 8.5%. Next. This is a tobacco-free status in Nagaland. Next. So we have 11 TCCs functional under NTCP, and one TCC Center of Excellence at Dimapur. And we also have 19 TCCs and at the sub-centers of Mogokchung district. And here, the CHOs are trained to provide brief advice on counselings and awareness to the patients on health hazards and consequences of the tobacco use, and the referral to the TCCs as and when required. Only 7 TCCs have station psychologists. The rest of the TCCs are managed by MOs. So wherever comprehensive counselings are required, patients are referred to TCCs where there is a psychologist. Next. So we focus, for best practices, we focus on the brief advice. Activities are primarily focused on the providing brief advice to all the potential patients during the outreach activities. All categories of health workers are trained in the districts to offer brief advice and referrals to the TCCs. NRT is provided only to the patients who are ready to quit, as NRT is expensive. And community-based platforms and engagements are utilized. Community participations and involvement is one of our strengths and strategy to reach out to the masses for tobacco cessations, awareness, and support. These activities emphasizes on the brief advice, education, and referrals to the tobacco, for tobacco cessation. And next, please. Counselings, referrals, and linkages are provided with close coordination amongst the OPDs, TCC, and the Centers of Excellence. Next. Motivation, counselings, and awareness is also considered as a priority responsibility of the healthcare providers at every TCCs. Okay. All the church is a major platform. So Therefore, leveraging on faith-based programs for tobacco cessation on counseling and support and referral services. And church camps are strategically structured to act as TCCs, focusing on addressing tobacco use among participants. Holistic approach like spiritual guidance, peer support, and health educations are combined to address the physical, emotional, and spiritual aspects of addiction. Next, please. In Nagaland, faith or churches plays a vital role in imparting moral values. Here is one of the picture of such session. Next. State Tobacco-Free Nagaland app, a state innovation which was launched on the 24th August 2021 to effectively monitor the TOFI guidelines compliance by the schools and easy communication within the TCCs and the NTCP team. Next. Tobacco-Free District Headquarters first launched in Nagaland, capital of Kohima, capital of Nagaland in 2019, and followed by all the 11 NTCP districts. It's an ongoing campaign. Next. Tobacco-Free School to Tobacco-Free Home campaign. This is an initiative of the State Tobacco Cessation Center in Nagaland to control smoking and exposure to secondhand smoke and consumption of smokeless tobacco at home. To take anti-tobacco message from schools to homes, each student will take this task as his or her individual responsibility to carry back the messages learned at school to their homes in the and each is in the ongoing activities. Next. So this is the picture. Next slide, please. Through the support of the project Eco India, so far we have around 300 teachers are already trained on guidelines, and our plan and strategy is to train all the teachers phase-wise. Next, please. So the notification issued to all the private health school institution and also in the to declare as the tobacco-free zone, and all educational institutes are also to declare tobacco-free zone. And the Empowered Committee on Article 5.3 FCTC was constituted on 16 to 23, June 23. So licensing of the tobacco vendors is in progress, and with this we hope that we'll bring down the uncontrolled sale of entry of tobacco products into the state, thereby reducing the tobacco availability in the state and also its usage. Next, please. So brief scenarios of the de-addiction. Nagaland is one of the highest prevalence rate in terms of opiates use, which is more than 10% in general population as per NDDTC aims. Nagaland is one of the top 5 states which has the largest population of people using sedative, have high percentage of people who inject drugs, high alcohol usage. State-specific practices. De-addiction center in the state provides a comprehensive package of all these kinds of substances abuse with in-house and out referral linkages, facility for addressing tobacco use, alcohol, drug abuse, opioid dependence, mental health are co-located with or around the de-addiction centers. This provides an opportunity for effortless cross-referral and linkages between the primary care services required for addressing all types of substance abuse. Next. Some of the state-specific initiatives for clinical support, the treatment facilities. I would like to emphasize here on the first point, the treatment facilities has already been explained. Second, a center of post-treatment follow-up for the psychosocial support and intervention established to strengthen recovery, which is named as Project REST, providing follow-up for the patient from 1 to 2 years, depending on the patient's post-substance abuse treatment programs, a Project REST, which is a success. Patient has to access to other medical needs. So youth-friendly drop-in center called City Barn. City Barn, okay, so City Barn is without I, TY barn. That is catch them young, be aware, reach on time. No to unsafe behavior is also an initiative of Nagaland, located in a youth-friendly areas outside of the health facility, provides counseling and referral services for substance abuse, tobacco use, HIV, STI, TB, and mental health, sexual root health, and then or family planning. This is City Barn is specifically for the young people below 25 years of age. Number 2, awareness and sensitization. Next slide, please. Community level approach. CHOs of all the health workers are trained to on tobacco cessation guidelines to be able to guide and support patients from the primary care level. And number E, students are particularly consult, educate, and enroll as ambassadors, messenger, or peer educators in this mission against tobacco use. So next, some lesson learned. This last slide. Comprehensive packages of services under one roof, which includes treatment and counseling for easy accessibility and decrease of loss of follow-up is a must. Cross-referral and linkages between the facility is also a must. Follow-up counseling for post-treatment phase for strengthening cessation and or recovery like Project REST and City Barn should be provided to decrease the relapses. Timely awareness of students and community level intervention, early intervention and treatment should be provided because addiction to substance is rapidly increasing in the younger age group in the state and in the country too. Patients also request other general care, so co-location of various services is vital. Equal partnership and collaboration response of government, local bodies, and civil society is indispensable for any program to be successful. Human resources, there is a shortage of human resources here. And lastly, at the end of the day, political will, political support, and leadership is the need of the hour if this battle against the addiction of any type and any form is to be successful. Thank you.
We would request you to stay back on stage. And ladies and gentlemen, may I request Major General Professor Dr. Atul Kotwal sir to kindly join us on stage to present the memento. While we have Major General Professor Dr. Atul Kotwal sir, the Executive Director of National Health System Resource Center, onto the stage presenting the memento. It's his next session. So we have the speaker right on the stage, and he's going to talk on research priorities and implementation research in non-communicable diseases. So, sir, it's already your session. Yes.
Good afternoon, everyone. It's okay. Respected ACS Health Andhra Pradesh, respected ASMD ma'am, JS Policy, all the other secretaries and MD and NHM from various states and UTs, all the experts, dignitaries, and all the participants. Very good evening. I know it's the last session with me and one more speaker after me. I'll try to be quick. We'll share the slides with you, and we can have subsequent discussion on this topic. When we talk of research in non-communicable diseases, it started since ages. And we all research is there for the communicable diseases. But I'll just give you one example of 1753 by James. A huge story. First time, no one believed him. He did it again subsequently. And of course, there were researchers with pellagra and all. And that's why, because of James Lind's research, British soldiers were called as limeys as long as till 5 years ago, when officially the terminology was changed, because fresh lime or lemon was part of their rations as such. And that's the power of research, which generates evidence and provides policy options to the planners and implementers as such. So, and tobacco as such, who we all know, from 1940s onwards, Sir Dole and Hill, they did a case control study first and clearly showed to the world that those who were smoking tobacco, and these are all the participants were British physicians. Those who were exposed to tobacco, they were taken as cases, and they had more illnesses and all as such, as compared to the controls who were not smoking. They were not exposed to self-smoking as such. And that time, no one knew what tobacco contains, how much is the temperature at the end of the tip of the cigarette when you are inhaling, or how many carcinogens are there. No one knew anything about that. So that's, again, the research methodology which comes to aid of the policy and also the knowledge. Then they established a cohort of British doctors only, followed them and started publishing from 1950 onwards, and over 30-year period, they clearly showed the power of the cohort study, the following of people, how tobacco leads to what all ailments we all know now as such. These are the factors which you all know. What I wanted to highlight here is we generally forget the socio-cultural and economic factors, and those are very, very important now when we talk of NCDs. The environmental, we don't know in reality what all environment will do to us, what all changes which are taking place, including air pollution, what we talk now, and this only time will tell. So we need research on modifiable risk factors much, much more, especially those two, and even these other ones, behavioral, physiological also, to fill in the gaps which are there. Analysis clearly shows, that publications have steadily increased, but more so in the developed world. And even our, as per the Global Action Plan for NCDs, there are a number of countries which are having the research frameworks is increasing, but again, it's only 2/3 are not having, only 1/3. And if you see in today's also talks by experts, if you can count the percentage proportion of Indian studies which were quoted by them, there's only 1 or 2. Majority were quoting the Western world. A lot of those are not applicable maybe to us. Even I'll give you an example of this thing, the experts, we can have discussion subsequently. Too tight glycemic control. How many episodes of hypoglycemia are linked to that? So we need to look at that, how much of our genotype and phenotype, how too tight controls are going to affect us, or too loose even. So we need to have those kind of contextual specific research available for our country. National health policy recognized this clearly. I've quoted few paragraphs, but the extract is clear. Collaboration, investment in research on health systems and services research, that's something which is coming up now in a big way. Medical product innovation, social determinants of health, Ayush in various parts of NCDs and other part of health also, publicly funded research institution and apex health institutions for research as such. These are, if you see the priorities, how they keep on changing. The Dole and Hill example I already cited earlier for tobacco. Similarly, there were other chronic randomized control trials were there. The other time, at the beginning of turn of the century, when Salim Yusuf and company, they all talked about large, simple clinical trials. That's where the clinical trials started on NCD management. We have quality of care started again in the turn of the century from Japanese, this thing of Kaizen and all to other kind of quality standards, and we started looking at quality care in NCDs. Health technology assessment came in subsequently, which is already going on now. And of course, now HPSR, digital artificial intelligence and implementation research is the era. This you all are aware. I'm not going to read anything about it, but just to put it in context, this is from the NP-NCD document as such, that these are the areas. And I'll give you few examples, few suggestions of what all research we can do to address each of these, which have been listed by NP-NCD document as the priorities as such in health promotion, screening, management, collaboration, monitoring, evaluation, and also collaborative research as such. So these are the few suggestions. If you see epidemiology, we think that we know about epidemiology as such, but no. There are large gaps which are still present. We need to look at what are the most optimal, sustainable, and scalable methods and tools for monitoring trends on morbidity, mortality, and risk factor. Surveillance, we talk about only communicable, we talk of IHIP. Now is the era with the number of deaths increasing of NCDs and morbidity also increasing and disability also reading. It's time for surveillance models for that, longitudinal following up of people. And that's where ABDM will also help us. We, as a developing countries, don't have cohort studies. It's only developed world. They are expensive, difficult to follow up. But we need to establish few cohorts in various parts of the country which you are able to follow up to see all these determinants on even behavioral risk factors. Quantification of personal risk. Another 5 to 7 years, you'll see personalized medicine coming up. In the end, I'll share 2 slides of future, what future entails. To look at the personal risk also to regard phenotype. One of the experts mentioned about different phenotype, but how different are we, and what are the issues, challenges in our management and follow-up and prognostication also. Databases again, nutrition is a field which we keep on changing our dietary guidelines. There are various fads, there are various experts which have come up, but what kind of research we need to look at these socio-cultural, economic, and behavioral aspects which are steeped into our nutrition as linked with that. Biological basis, again, poverty as well as excess wealth. Both needs to be researched. These are few topics. The list is huge. I'm just sharing few which I thought were probably important to address immediately. When we come to the prevention and promotion of NCD healthcare, which is a lot of focus is now there, starting from the community-based assessment to Ayushman Bharat onwards. Cost-effective interventions are very important, especially for low-resource settings like India, where funding will come gradually as such, but right now, how to look at this cost-effectiveness, risk factors, feasible non-pharmacological lifestyle interventions. There's the risk of, we experts from NCDs and all in the last turn of the century onward started victim blaming the individuals. You are having diabetes because of you. You don't exercise. You don't eat well. You are having hypertension because of you. So it is time we start giving them solutions. So these are the non-pharmacological interventions which are effective, and these are the options, and this is what you can tailor-made for you as such. New biomarkers will come up and new diagnostic techniques will come up, but again, we have to validate them. We can't just copy-paste the West, that these are the biomarkers. They will be applicable for our phenotype and genotype also. Modeling for early detection and risk prediction, just like communicable diseases, we need to now look at those maps, isopleth and chloropleth maps and those techniques and all also, to look at the modeling techniques for what are the outputs and what are the outcomes, and how they are linked with the other NCDs. And again, the gaps in availability, accessibility, and affordability of treatment. Should everyone be going to this thing, tertiary care, and also how to strengthen our district hospitals and CHCs. And again, people living, how they can be enrolled themselves, self-help groups and all, even patient support groups, how effective they are and how they can be improved. Self-care interventions I have already mentioned earlier. Curative, again, best practice for holistic care. Diagnostics and drugs and vaccine affordable, as well as I must mention here, which I'll repeat later, the validity and ethics and data. When we talk of diagnostics, I'll come to this point subsequently also. Cancer vaccine, you would have all read about coming up with the cancer vaccine. How good are those claims? And what is the use of cancer vaccines in therapeutics and also prevention of specific cancers? It's time we start research on that also in our country. Again, public-private partnership, which models are effective? Health systems and policies. HPV DNA screening we have been talking about, but as pilot in one of the states clearly showed the challenge in ethics. Because earlier we thought that an individual, a lady with the VIEA positive, there's a stigma for cancer which we are trying to address, Now she's getting a report that you have an infection, HPV. So how many of them will come up? How many of them will tell this? That's where the ethical part comes in when you talk of mass application of any kind of screening. Again, NCD prevention, Ayush contribution, task shifting in NCD, where the roles of specialists are taken by MOs, or MOs are taken by nurses, nurses are taken by ANMs, and even now CHOs and ASHAs and Anganwadi workers also to be included. Monitor effectiveness of the program as such, and role of informal sector in this. Technology and digital health, I'll come up subsequently also. Again, crisis, COVID-19 showed clearly the impact on the NCDs. A lot of people did not move out of their houses, did not get medicines on time, and we need to look at that kind of research to tell us how to effectively involve all these people, how to ensure that they get the care which they need during any kind of conflicts, displacement, disasters, disease outbreaks, pandemics, etc. Again, for advocacy, we need to generate evidence where we talk about economic benefit on return on investment on ensuring prevention. So the funds being spent on prevention and the modalities, and again, access to care. We need to have more funds. We have done some study, we've done costing, but to generate those funds, we need effective advocacy where we have evidence-based that, yes, this is what we are going to achieve and save. Again, effectiveness of legislation, regulation, and taxation also. We have been taxing tobacco products, sugary drinks, and also alcohol. How effective they are in changing the knowledge is there, attitudes are there, how effective they are in changing the practices and on-ground implementation as such. So, towards the last part of my presentation, I'll come to implementation research, which we do regularly as such. The leaders and all, as you all know, those who are sitting in front rows, you all need, the implementation strategies. We worry about those, that what are the policies there, how are we going to implement it, what are the challenges likely to be. And implementation research helps in filling up these gaps by identifying the challenges faced, framing and answering the questions in a scientific method. There is a significance, the generating evidence, models for implementation, context-specific, target approach, practical solutions to theoretical problems, investigates facilitators as well as barriers to implementation, policy action, service delivery, best practices, local community empowerment strategies, and also creates healthier populations eventually with IR. This was initial studies. Last 3.5 years, we've done a lot of work in implementation research when we established it KMD in NHSRC, joined as ED NHSRC. Again, victim blaming, I'll mention here again. We say people are not adherent to medicines. This review clearly showed the treatment adherence is high whenever access improves. So we have challenged the assumption of patient negligence or victim blaming as such. You make it available, adherence improves. Non-compliance stems from distrust in medicines, poor disease understanding, treatment fatigue, and access issues. Address these issues, immediately compliance improves. Again, limited public health services that we are strengthening now as such. After 2018 onwards, we all know there's a tremendous reach and availability, accessibility as such. Private sector use always leads to high out-of-pocket expenditure affecting adherence. Community-based services should adopt a population-based approach covering all households. So we need to look at, again current strategies also. This has been published in one of the international journals. The other is leveraging digital technology. Are our ASHAs ready? This study done by AIMS and NHSRC combined and under the approval of the Ministry of Health as one of the implementation research projects, that ASHAs can be successfully trained in a very, very short time. Time taken for family courts significantly reduced by 25 minutes, workload reduced, and overall work efficiency improved as such. This is a study again done by AIMS, referred to in the NDA also of the continuum of care, and the CDSS for that, the clinical resilience support system. It showed clearly that it assisted the healthcare workers to tailor the guideline-based care to individual patient needs. They did not have to, think much or write some other combinations or drugs which are not available. Drop-down options were there as per the recording, as per the history. Options were given to them. There was a bypass option also available to the medical officers, but it helped them in strengthening the continuum of care also. Standardization of care, reduced their workload, and better control of hypertension and diabetes overall improved the quality of care. We also looked at that how, the adoption of technology can be improved. These are the factors which came up clearly in one of the implementation research, not published as yet, that perceived value of technology by the healthcare workers, that has to be improved, shown. Community acceptance, availability, economics, again, incentives of some out-of-pocket expenditure, apprehension toward privacy and personal information, compatibility with workflows, and also governance factors. Once we address all these, then only the technology uptake will further increase and further improve our usage of the digital technology. This is the ongoing IRHSS after the approval of Ministry of Health, collaboration between NHSRC and WHO India to improve continuum of care and people-centric integrated NCD care delivery. In 13 districts of 5 states I have mentioned here, and we are looking at identifying and narrow gaps between key policies, programs, and services. These are the objectives. I'm not going to read this. Basically, it is strengthen the entire system without any additional finances. We have the adequate policies. We have appropriate HR on ground, which have been trained to leverage that only and look at the gaps first as per the policy which should have been there, fill up those gaps, and try to create the continuum of care model which can be replicated and upscaled immediately in all the states of the country. So this is what we have done till now. If you see the last point, we've also integrated CDSS into these 13 districts. I showed you one slide where I showed that CDSS definitely helped in efficiency, but that was done in 2 districts in 1 state. After this, in 13 districts, then we can go to the ASMD ma'am and JS policy and present over there that this is what it has shown, and it's definitely improving, then that can be upscaled immediately. We have already integrated CDSS in these 13 districts. What is left now, training of the healthcare workers in CDSS of these 13 districts, which is planned for next week. We already trained the nodals of these 5 states. Data collection analysis, and we are planning to have initial results by August of this year, within 6 months, and follow up till February next year for the final results and recommendations. We were thinking of having some national workshop and all, but that would have delayed. So without that, we are starting. We'll go to visit states and sit with the states and work with them. Just quickly, 2 slides, what future indicates. We must know what future is there. It is there, and we have to, address that. We need strategies, both financial as well as programmatic to provide. I've written the question, can we incorporate them someday? The ideal question is not can, ideal question is when. And for that, we need programmatic approaches, and for that, we need some kind of implementation research and also some translation research also. Artificial intelligence, you all are aware, a lot of modalities available, but we got to be careful about the validity, the sensitivity, specificity, positive predictive value, negative predictive values, odds ratios before and after, ethics and data privacy and data safety. Liquid-based cytology is again coming up, newer modalities for cervical cancer screening. Point of care HPV molecular, we all are aware. Again, for the diagnosis and monitoring liquid biopsy, this is very interesting that, the circulating tumor DNA, that is now being looked at by the West to provide as an early marker for screening of CA breast. That's something which is unique, which we need to do research on our genotype and all before we start using this. And other, like PET MRI is now coming up instead of PET CT to reduce the dose of radiation significantly. Personalized care using technology, immunotherapy is coming up, immune checkpoint inhibitors are coming up. But again, how much are they costing, and how we can make them available for all of their population? In MSI, these are new biomarkers. CAR T cell therapy, we all are aware. But again, how to make it indigenously, how to again make it effective, cost-effective as such. Targeted, I think we all know, but it is now going to be expanded to more diseases. I think I skipped one slide. Collaborative research as such, I think yeah, okay. So last 2 slides, that if there's so much as there in future, why should implementation research lag behind? So we collaborated with Jawaharlal Nehru University CSMCH. I spent 1.5 years there doing my epidemiology training after AIMS. So I knew their strength in this area. And we got some experts from other parts of the country also, including other countries also. So that's, we have come up with this dialogic health system research framework. The HSPR, when we talk of health system policy research, there's too much of diversity. The experts don't talk to each other. The organizations don't talk to each other, and various kind of results which you are getting. And to overcome this confusion, we decided that there's a common research framework, or HSPR was required to understand, describe, and explain the system structure and functioning, and make sense of the HSPR so that it's easily presentable to the planners, to the leaders, and those who are involved in governance of this thing. That is the output of research. We have already submitted a paper and the research proposal to the ministry as such. And this is what the methodology, which draws from the framework, draws from principles and complexity lens which is context specific within the entire country as such. And again, open diverse perspectives, different settings, value critical and dialogic. This is too much of theory, I know, but a framework was required which we have prepared, which can be used by any organization in the country to use that for any kind of implementation research. And maybe it's dynamic. One can always give more suggestions and improve it further. Thank you very much for the patient listening. Thank you.
Thank you so much, sir. We would request you kindly stay back on stage and requesting Mr. Krishna Babu, sir, IAS, Special Chief Secretary to Government, Health, Medical and Family Welfare Department, Government of Andhra Pradesh, to kindly join us on stage and present the memento to sir. Can we have round of applause? And now moving ahead, ladies and gentlemen, I take the privilege of introducing our next speaker, Dr. Pallavi Shukla, Associate Professor, Preventive Oncology, IRCH, AIIMS. And the topic Dr. Pallavi is going to speak on is about research agenda in prevention and control of non-communicable diseases. Can we have Dr. Pallavi ma'am to kindly join us on stage?
Very good evening, respected CDS, ladies and gentlemen. So I'm here to talk about the research agenda in prevention and control of non-communicable disease, which sir has actually taken care of very well. Let's see how I'm going to fill in the gaps. So everyone here, no one can deny the fact that there is a huge rise in the burden of NCDs, and we have come to the status of this knowledge by a lot of work done by the researchers. And to name a few very important research studies in this regard are the National NCD Monitoring Survey, undertaken by NCDIR, another India state-level disease burden study undertaken by ICMR, PHFI, and IHME, and also INDIAB study. And all these studies have focused one thing, that yes, there is a huge transition which India is seeing in the burden of disease. We are shifting from communicable to more non-communicable side, and non-communicable disease along with injuries have outgone the childhood illnesses and the infectious diseases. So definitely research is of paramount importance because it helps in generating data. And data is something which is most needed once we are framing policies. All the policies are data-driven. So I'll just give you a very small example. We have, with our concerted effort, we have managed to reduce the maternal mortality to 2 digits. Now, every year, we are seeing around 24,000 maternal deaths, which is far less than what we were seeing in last couple of decades earlier. However, can anyone guess the number of cervical cancer deaths that are happening in a year? It is 3 times the maternal deaths. It's around 77,000. So we are saving a woman from death related to maternity causes only for her to die later because of cervical cancer. Hence, data counts, so we need to put data on. So there are current gaps in NCD prevention and control research. There is limited data. We have inadequate national and regional data on risk factor and disease prevalence. Let's talk about the cancer registry data. We have 28 population-based cancer registries and 58 HBCRs. Yet the coverage of population-based cancer screening in urban areas is less than 15%, and in rural areas is less than 1%. We need continuous flow of this data. And a huge data is available with the health system delivery side. All we need to do is arrange a marriage between the researchers and the implementers. Then preventing the neglect of primary prevention strategies. We need to focus, we have seen in the past few sessions so much talk about the modifiable risk factors. There are also upcoming new risk factors. So we need to focus our attention on primary prevention strategies because the way the NCD is rising, it is going to cripple the health system if we do not curb the growing burden. Then screening gaps. So whatever screening strategies that are applicable to the Western countries may not be sufficient in the Indian context. We need to devise our own screening strategies. And I will also talk about it in detail later. Then there is limited evaluation of community-based intervention models. We have very good researchers from various institutes and small geographical areas which have shown good research in NCDs, in NCD preventions, in technology advancements. However, these studies have to take shape in the real-world scenarios. And for that, we need a lot of implementation research studies, as Sir has rightly mentioned, translating these research findings into practice. So we require an agenda which comprehensively covers the NCDs, starting from generating data to make it useful for framing public health policies and integrating all the approaches, a holistic model starting from the primary level of prevention, secondary, tertiary, and rehabilitative care. Then it needs to address the regional and the demographic variations in NCDs. It's not just, India is not just a country, it's more like a continent. We have so much variation in terms of population, we have so much variation in terms of health system infrastructure. So these things have to be catered in our research agenda. Then leveraging advancement in artificial intelligence, the genomics, and the telehealth solutions. We are day in, day out bombarded by intelligence, artificial intelligence, and all these advancements. Why not utilize them in a more fruitful way in developing more important health system reforms? Then aligning these global NCD targets while taking care of the local needs as well. So this is a double diamond model which companies use to find creative solutions and innovative ideas. Let us take this model into our research considerations. So it also has 4 stages from problem to reaching a solution. So understanding or discovering what the problem is. Here the problem is NCD and the risk factors and the emerging new risk factors. So discovering those things, then defining the entire disease characteristic and the risk factors. Finally, identifying or developing solutions to cater to these risk factors and developing solutions to provide care for these NCDs. And last but not the least are the low-hanging fruits, that is the deliverables. The strategies, the technologies which are already tried and tested in small settings, we need to deliver them and implement them on a large scale. So the key areas of research will actually hover around these 3 levels of prevention. That is the primary prevention, taking care of the risk factor reduction, secondary prevention for early detection and screening programs, and research tertiary prevention, that is improving the management of chronic disease. I will list out few of the research areas as per the categories. So first is prioritizing the research areas in terms of understanding the risk factors and its determinants. So few are the modifiable risk factors, as has been time and again enlisted: alcohol, tobacco, unhealthy diet, and unhealthy lifestyle. And also the emerging risk factors, like we were talking about genome profiling in our previous session. Then preventive strategies to develop cost-effective interventions to reduce the NCD risk. So few of the research topics could be effective policies to reduce the tobacco use, the alcohol consumption, and even talking about the pollution levels, not just the air pollution, but also the water pollution. And then impact of community-based physical activity programs. Then early detection and screening. So some of the research topics that could be development and scaling of affordable diagnostic tool. So I'm proud to say that India is one of the countries who actually gave important studies like evaluation of VIA as an affordable screening tool for cervical cancer screening. CB, clinical breast examination, as a low-cost screening tool for breast cancer screening, wherein the West is going forward with the mammography-based screening. Similarly, integration of NCD care into the primary healthcare system. So right now, we are engaged with ICMR's multi-site study in which we are actually trying to enhance the coverage of population-based cancer screening across multiple sites, and improvement in the treatment. Then policy system then development of affordable, high-quality treatment options, and policy and system research to strengthen health systems to address the NCD burden. Evaluating multi-sectoral policies addressing NCD risk factors, like collaborating with other organizations and other sectors which are also working on the common risk profile for the NCDs. Then innovative technologies and data utilization. Recently, we are also engaged with the artificial intelligence and machine learning in breast cancer and oral cancer screening by developing the clinical decision support system. So we need not neglect the equity aspect whenever we are focusing our research agendas, because underprivileged will always remain underprivileged if they are not adequately taken into consideration. So access to prevention, treatment, and care in the underserved population, and then gender-specific approaches to NCD prevention and management. So what are the challenges that we find in NCD research and implementation? Number one is funding and resource constraints, especially when we talk about risk factor studies. Nobody wants to invest in risk factor studies because there are time-taking studies and they require a lot of effort, and researchers have to actually let go of this idea of risk factor studies because they are never going to get enough funds for that. Second is limited awareness and capacity at the grassroots level. Everything these days is banking upon ASHA workers. So we really need to look forward to some other mechanism to touch the population. And the need for intersectoral coordination. So last slide for the day is call to action. So prioritizing the NCD research in the state and national health agendas. It's time that the implementers become the researchers. It's time that we sit together and work on the research ideas so that it can foster better partnership between researchers and policymakers and community leaders, and commit to a sustainable funding and resource allocation for NCD prevention. Thank you.
Thank you so much, ma'am. I would request you to kindly stay back on stage. And may I request Mr. Parthasarthi Sain Sharma, sir, Principal Secretary, Uttar Pradesh, to kindly join us on stage and present the to Dr. Pallavi, ma'am. Thank you so much, ma'am, for that information-filled presentation. We had a productive day filled with insightful discussion, thought-provoking presentations, and meaningful exchange on critical aspects of non-communicable disease prevention, management, and control. So ladies and gentlemen, before we wrap up, I'm delighted to inform you all that the special cultural event has been organized for all of us at Geo Gardens, and starting at sharp 7 o'clock, so we would request your presence right at 7, because the team is all set to mesmerize you in the evening, and it will be a wonderful opportunity to unwind and enjoy the vibrant culture heritage of our Telangana region. Thank you once again for your participation today. We look forward to see you tomorrow morning for the Day 2 workshop, which will start at 10 a.m. Thank you, ladies and gentlemen. Have a happy evening. And also requesting anybody who would like to give the samplings, like fasting samplings, the people will be available here from 7 a.m. tomorrow morning. So you can come over here and give your blood samples for from 7 a.m. Thank you.